And recently I joined with Dr. Canelli. I am her medical advisor or clinical advisor in their clinic. And we joined forces. We're trying to upgrade the system, me and her, so that we will be uh, developing a flagship of a medical center that can be replicated. And basically, we are doing systems medicine, which is a field of medicine that manage chronic diseases by restoring the systems, all the systems of the body, not just specialists who are focusing on one system. We need to really, if you want to manage any chronic disease, because most of chronic disease are systemic disease, it cannot be fixed by one system or by knowledge or treatment of one system. You really have to have the understanding of how to normalize the redoxin, metabolic, and immune and regenerative from all the systems of the body, or through all the systems of the body. And so I'm giving you an example. Alzheimer, if you go to neurologists, they say, okay, Alzheimer, that they have a neurodegenerative disease in their brain, especially the cholinergic neurons are not working. So they have low acetylcholine. So what we will do, we just have to increase acetylcholine. So we give them drugs that inhibit the degradation of acetylcholine. It's called acetylcholine esterase inhibitors. And if we do that, then we increase this acetylcholine and we treat the Alzheimer. That's what the neurologists do. Us would say, well, uh, what causes neurodegeneration? And can we solve the process of the neurodegeneration? For the mainstream medicine, they consider that all those neurons are dead and we cannot reverse them back. In integrative medicine, they say not all of them are dead. Some of them are stunned by inflammation, and we can wake them up if we treat the inflammation itself. So some of those neurons, they are just stunned by inflammation. Some of them are dead, which we cannot really regenerate them. That's true. But maybe 50% of those neurons that you think they are dead, they are not. They're stunned by inflammation. And we can regain their function by removing those factors that cause inflammation. And so we start looking at, okay, so what is the trigger of the inflammation of the brains? We think about, okay, it could be because of the leaky gut. The gut is leaking inflammation, which constantly getting into the brain and causing the inflammation, stunning of the neurons. It could be leaky gum, not leaky gut, leaky gum, inflammation in the gingivitis. It could be the patient has allergies. The patient has diabetic, or patient has autoimmune disease, rheumatoid arthritis, or patient has toxins or chronic infection. All of this can be a source of a free radical generators that leading to this constant inflammation and speeding the process of the degeneration of the neurons. And if we neutralize this, those inflamed neurons, some of them will reverse and regain its function, and we can slow the process of the new generation of the Alzheimer disease. Plus, we have the waste of the brain itself. We may, those prions or those proteins or misfolded proteins, we may able to clean them up. We're using curcumin or using methylene blue or something that helps them to be recognized and activate the autophagy and kill them and get rid from them. So possibly curcumin, methylene blue, quercetin, things like this may help and getting rid or recycling and getting rid from those prions or those misfolded proteins. So that's how we think. Also, we think to give them exosomes, those regenerative factors in the exosomes and anti-inflammatory may help in the process of the healing and slowing the process of the new degeneration. We think about peptides as signaling molecules that helps to stimulate the antioxidants and anti-inflammatory and possibly slowing the process of the new generation. So that's how we think as a systems medicine. We don't just think about, okay, the problem is in neurology, it's in the brain, then we need to only focus on what problems in a neurological system. But the reality, Alzheimer can be a problem in and metabolic. It could be hypothyroidism. It could be hormonal. It could be low sex hormones, right? Too. Low sex hormones will speed the process of the degenerations of all your body. Why? Because sex hormone are regenerative molecule, right? And when it's low, what will happen? Then your body needs to have some sort of steroids to calm the inflammation of the body, so they start producing cortisol as a replacement for the low level of the sex hormone. So the low level of sex hormone that happened at the age of 50, it will be compensated by cortisol that's being pumped by your adrenal gland, right? Because we need to decrease the inflammation of the body with those steroids. But the steroids of the cortisone, they are degenerative. The steroids of the sex hormone are regenerative. And so what will happen here, you are switching from being sex hormone dominant, regenerative dominant steroids into degenerative dominant steroid. That switch leads to speed the process of the degeneration and aging. Cortisone also leads to the whitening of the hair, wrinkling of the skin, and speed the process of the aging and the degenerations of all the systems, not just the brain, but every part of your body. And it stimulates the fibrosis, and the fibrosis will replace the parenchyma. And so, in order to prevent that, then we really need to restore those hormones of the level of the body. And the big disaster that we have is that causing all the problems that we have is the insulin. As we know, insulin is the problem, and insulin, because of our food, is high carb and a lot of free radical generator inflammatory of our food. All those chemicals in our food is causing the insulin resistance, which will lead to insulin to be high. And when the insulin is high, the insulin can stimulate the mTOR. And when you stimulate the mTOR, you stimulate cancer, right? So insulin is high, causing what? It's causing cancer by stimulating mTOR. Is that how? Well, it's more than that. Insulin also causes the immune system to be compromised, especially the cytotoxic T cells, the natural killer cells. When it's high and you have insulin receptor resistant, then your immune system will shift away from cytotoxic T cells into Treg and Th17. And so so what would happen is that you compromise the immune surveillance, and that will lead to the risk of the cancer. So insulin leads to stimulation of mTOR, and also it compromises the immune surveillance function of the cytotoxic T cells and natural killer cells. Okay. Insulin also stimulates the NOx enzymes, generate free radicals. And too much of free radicals, too much of Th17 mediated inflammations leads to mutations on the DNA, and that leads to what we call the genetic mutation, and that trigger the cancer, because anything that leads to chronic inflammation can lead to cancer. And if you see that insulin is the bad guy, it's a cancer driven, it's a factor, it's inflammatory driven factor, and it compromised the immune system against cancer and also viral infection and intracellular pathogens. And you can have high insulin 5 to 10 years before you would have your abnormal hemoglobin A1C and abnormal glucose, fasting glucose level. And not just that, insulin is the reason why we have atherosclerosis. And then what will happen? You will end up decreasing the tissue from oxygen because of atherosclerosis and narrowing your blood vessels. So you have what? Hyperperfusion, low oxygen. And the low oxygen in the tissue also, it's a driver of the cancer, right? Because then the mitochondria does not work. And if the mitochondria does not work, you compromise that little bomb that actually triggers when the cells become cancer. It we call the mitophagy. Mitophagy, part of it is to get rid from the cancer. And if you compromise that mitochondria from low oxygen, then also that may lead to compromising the mitophagy, which is one of the way that we can get rid from the cancer. And then the insulin itself stimulates the fibrosis. And the fibrosis is too much of fibrosis replacing the parenchyma. That speeds the process of the aging. but also it's the fibrosis, especially cancer-associated fibrosis. It can lead to squeezing the blood vessels, preventing infiltration of your immune system, infiltration of the red blood cells, and preventing your chemotherapy from going in as well. And so if you see that insulin really is the culprit, is the reason of the aging, of the inflammation, of the disease, and the first thing you need to do is to normalize all your patients' insulin. I used to say below 10, but the reality is that let's do it below 5. That's the optimal. I mean, below 10, we call it normal, but optimal is below 5. And if you have it below 5, the insulin level, most of the time that patient is healthy. And most of the time, if you see a patient with visceral fat, then most of the time they have insulin resistance. So anybody has little belly in his abdomen part or some extra fat in his abdomen part is not healthy. His insulin is high, and that insulin will drive him into cancer. So he has high risk of cancer, aging, inflammation, and death. And we know that the chance of the cancer of anybody throughout his lifespan is the chance of flipping a coin, 50%. You're going to have cancer during your lifespan. And if you go to the graves, 1 of 6 of the graves death goes by cancer. So cancer is a crisis, and it's not being managed. And now we know there is a hidden crisis that really is the reason of the cancer, which is the high insulin. And those high insulin, it's not just the food or the high carb. High insulin can be also from the toxins, because toxins generate free radicals causing insulin resistance. So anything that oxidize your insulin is actually will lead to a cancer, because it will lead to insulin resistance. As a reflex of that, it will lead to increase the insulin, and the insulin will drive all those problems that we talked about. So when we manage cancer, we don't just think about destroying cancer, because that's what most of the mainstream oncology up to now, they think, okay, so the whole purpose is to kill cancer. So give them chemotherapy, radiotherapy, and immunotherapy, which is good, right? So immunotherapy is something, thinking outside the box. It's part of the tumor microenvironment, which is a good thing that oncologists are thinking about enhancing the immune system using those anti-PD-L1, anti-CTL4, anti-PD-1. All of this is already FDA approved, which will enhance the immune system, and shifting the Tregs to become cytotoxic T cells and killing the cancer. So it activates the cytotoxic T cell, which is a good thing. And then also the chemotherapy, it does interfere with the molecular pathways, because that's what the mainstream medicine thinks. It's all about, okay, so what's the difference in the chemical pathway of the cancer of the normal tissue? Oh, the difference is that we need to block this pathway because it's more active in the cancer than the normal cell. So let's block that, right? And so we get all those drugs and all chemotherapy to target those pathways where it's more active in the cancer than in the normal cells. Although it's not purely going to just inhibit the cancer cells, it's also going to help the normal cells that divide and proliferate. That's why you have hair loss and all the skin problems and problem with your liver, jaundice, and all that stuff, because it will interfere with all the high proliferative cells, including your normal proliferative cells, high proliferative cells. And so like the bone marrow and the hair and all that stuff, because there's commonality between those normal high proliferative cells and the cancer cells. So that's what they do. And also some of those chemotherapy, they generate free radicals and induce the cancer. I like mebendazole and ivermectin because they work more specifically to the cancer than the normal cells. They interfere with a pathway, especially the cancer stem cells, the Wen pathway. There's many of them, Higgs or whatever. There's names, different pathway, but it's more unique in those cancer cells versus the normal cells. So the more that you block pathways that is specifically in cancer cells and they're not much in the normal cells, that's better, right? Because then you have less side effects. But if you're blocking a pathway that is more in cancer, but still in the healthy pathway too, you will end up with some side effects. But how you can minimize the side effects is to get those drugs into the cancer, not everywhere. And how we can do that, how I can get the drug to, which is a poison for more for cancer than healthy cells, especially after you do cancer sensitivity testing, which you take those chemicals and you test them and you find out that the cancer is sensitive to that test or that chemical. You don't want to give a chemical chemotherapy that the cancer is insensitive to, right? Then that's a problem. Then you will be suppressing more the immune system, and that will speed the process of the death. So your chemotherapy actually will cause death, speed the process of death, than keeping the patient by itself. So it's very important that we take those chemotherapy and we find out from those genetic testing or are using similar to we do with antibiotics, where we take a culture of the bacteria, we put a tablet there, and we see the death of the bacteria around the tablet. The same thing you can do it to cancer. You can grow cancer in vitro, and then you put those chemicals and see if they are sensitive or not. But also through genetic studies, you can know whether this cancer is sensitive to that chemotherapy. And then you get those chemotherapy and you say, okay, those are the chemotherapy, but how I can get those chemotherapy into the cancer, because it has some toxic effect on the normal cells, especially the high proliferative cells, like your hair, your bone marrow. So how I can just push it more to the cancer cells. Then you need to think that what's the difference between cancer cells and normal cells? The difference is that the blood vessels and the cancer cells, they are leaky. The normal cells, they are tight. So if we pack those chemotherapy into vesicles in the size of 100 nanometer, then those size 100 nanometers will not go to normal tissue, because the tight junction of normal tissue is very tight, small, and they will favor the leaky blood vessels of the cancer. So that's called nanoparticle, nanomedicine, nanotechnology. And that's what I do. And that's what I train doctors to. Um, Let me see if I am recording. Are you recording? Yes. You're recording too, right?
As far as I could see, the recording is on.
It's on. Okay, good.
Yes.
And so what we do, we say, okay, well, we're going to load them inside liposomes. That's why we end up with Doxil instead of doxorubicin. Doxorubicin is a chemotherapy that generate free radicals, by the way, and induce apoptosis. And we put them inside liposomes, right? Pack them inside liposomes, and then we call it Doxil. And we don't need much of doxorubicin dose of the naked one. We reduce it maybe 50% um, less than doxorubicin, because they're wrapped inside the liposomes. And we think that, okay, because of those liposomes will be favoring a leaky blood vessels, which is inflammation or cancer, versus the normal tissue. So that's called targeted therapy, targeted nanotechnology. And most of the chemotherapy, they are now loaded inside liposomes, or loaded with inside the PLGA, which is polymers of carbohydrates, or loaded inside cyclodextrin, which is also a polymers of sugar as well. PLGA is more pharmaceutical. Cyclodextrin is more grass, so they can use it for supplement as well to enhance the delivery and the targeting and stability and minimize the degradation. And then there is another way of loading those drugs inside exosomes from the stem cells, or inside platelets nanoparticles. So I can take your platelets from the patient, I put it with the drug, sonicate it, break it down, release those ghost membrane of the platelets and possibly their exosomes that's inside the platelets, and then sonicate it with drugs and load them, and then non-extrusion by passing it through a filter back and forth, and then do some sort of nanofiltration. You get all those vesicles, or clock it, those drugs inside those platelets membrane, or platelets nanovesicles, or exosomes of the platelets after they rupture. And I pack them into the size less than 250 nanometer, through nanofiltration, and I give it to the patient. And they made a study between doxorubicin and doxorubicin loaded with platelets nanoparticle, and we find out that the doxorubicin loaded inside nanoparticles are concentrated more into the cancer than doxil with liposomes, and then doxorubicin, which is the naked chemotherapy. So I like the platelets nanoparticle loaded with drugs over doxil and over naked drug, doxorubicin. And the reason you'll say, well, that's liposomes and that's platelets nanoparticle, which is a membrane and membrane. So why, liposomes, which is the doxil, that's a big pharma has it, which is FDA approved, is less effective than the platelets coming from the patient's membrane? Well, both are membranes, phospholipids. But the membrane that's coming from the liposomes is synthetic, and still your macrophage sees it as a foreign. So when this liposomes loaded with doxorubicin gets in there to the liver, macrophages, or pancreas or lung, they intercept them. They see, oh, it's still your foreign. And so if you have a cancer in the brain and you're doing an IV, anything that passed the pancreas and the liver will be intercepted in the lung by the macrophage. So you have few going to your brain cancer. But if you load inside platelets nanoparticle, which is part of the patient's platelets, the macrophage says this is self. Oh, this is us. We're not going to intercept it. All right. And so that's the reason we find out that platelets concentrate loaded with nanoparticle, and it's better. It's coming from the patient, more cheaper, more affordable. You just take those chemotherapy, low dose, 10%, 20%, loaded with platelets nanoparticle, and there's a big pharma who's doing it. It's called Silo Therapeutic in California, San Diego, and they have a lot of studies already. It's a big pharma, so it's not something that's coming out of the blue. And in the future, they think that all the chemotherapy will be loaded inside platelets nanoparticle and platelets. And we can donate platelets like red blood cells. They are not that immunogenic particles, so we can give platelets from one person to another. They are less immunogenic, or they're not that immunogenic, so you can get plasma transfusion from one patient to another, right? Which
Hey,
we can
Dr. Halasa,
platelets. Yes.
um, do you want people to wait until the end to ask questions, or Dr. Kelsey, you might not be able to see, has his
So
hand up?
anybody has questions up to now? Anybody, if you want to go ahead and have questions, do you have questions?
Hey, Dr. Lassa. Yes, I had a quick question. Uh, I know that doxorubicin, if you pick it up from the U.S., it's very expensive. If you get it from overseas, it's a fraction of the cost. If you load it in the carrier that you're suggesting, do you know what the rough out-of-pocket cost ends up being per month?
I will let you know when I start, because the prices are different, and I did work more with Germans.
Uh-huh.
But when you get it from the compounding pharmacy and they source it, and it's gonna be more affordable, you know, especially if you get the compounding pharmacy doing chemotherapy. You get the APIs. Yes, if you get it from generics from the insurance company, or in other words, regular pharmacy, cash, it's gonna be expensive. So what I will do, I will connect you with the compounding pharmacy who can supply you a cheaper version of generic of the doxorubicin, where you can have it cheaper. But I don't know the prices. It's not in my mind right now.
Okay.
I know those vials, it costs around 300, 400,
Yeah,
but
about that.
you can get less if you work with the compounding pharmacy.
Okay. And that's with the platelet derived
No,
nanoparticles.
no, no. So
No,
so
no.
that's the thing. Um, Maybe from the compounding, because you're not using the full dose of the chemotherapy that the patient need based on the big pharma, the full dose
Right.
of doxorubicin, you only need 10% or 20% of that dose.
I see. I see. Okay.
And so you can do it with no caps,
Mm,
right?
makes sense.
And so it will be more affordable for the patient because you're going to use 10% to 20% that dose.
Yeah.
So let's say the vial costs $500 for the full dose. Let's say, for example,
Hmm.
you'll be using it more prolonged till you get rid from the cancer, no caps. Because the cap from the regime of the big pharma, the reason why we have caps, like they say, you can only do a course of 3 months of chemotherapy, and after
Right.
that
Right.
you cannot do anymore. The reason is not because um, the problem of affording it or the insurance will not pay for it or things like that. No, it's the if you go beyond the regime, you'll be suppressing the immune system, and so it become worse than its effect.
Yeah.
So that's the reason the cap of the mainstream medicine because of the suppressing of the immune system. That suppressing of the immune system, it's not a problem with us because first we use low dose and we use nanoparticle to target into the tumor, and possibly we also do intratumor intranodal, which is injecting into the lymph node, that's swollen lymph nodes, and also the tumor. And so we don't have the systemic effect, so we don't have the caps. So we
Yeah.
cannot
Because
say to the patient, "Oh, you know what? You got the course of chemotherapy. You need to wait for 6 months, 1 year to get the course." And during that time, the patient is dying in the hospice, and that's it. We don't have any other solution because we cannot give him chemotherapy. His immune
yeah.
system will be suppressed. The same thing with radiotherapy because I experienced the same thing with my dad. They say
Right.
we do a course of radiotherapy, we cannot do it anymore. If you do it, you will suppress the bone marrow and you compromise the immune system. And the studies find out more harm than more benefit. Does that make sense?
Right. No, it does. It does. I mean, I have a pretty bad stage 4 colorectal cancer patient, and she's got disseminated disease everywhere. But when I did the RGCC testing on her, I found that her cancer would be very, very sensitive to doxorubicin and Avastin. But when her oncologist has tried that in the past, it's been very toxic to her, so she hasn't been able to tolerate the therapy. And that's why I think what you are offering is profound, and I think uh, uh, would really change the game for patients like her, because then we could offer her a lower dose, less toxic dose, but still effective for a much longer duration. And I think that would change things for her potentially.
All right. And you do both. You can do the IV.
Uh-huh.
Plus, you can take some of those medication. If she is stage 4, she has lymph nodes. You
It
go to
does,
those
yeah.
lymph nodes and you put just 1 ml in them. Depending on the size of the lymph node, but I can help you with the volume because you can use the AI. Tell her, okay, the lymph node size is 2 centimeter. How much of you think platelets nanoparticle loaded dose doxorubicin? How many mil I'll put each lymph node? You don't want to do it too much where you press the lymph node and causing necrosis too much. So there's dosage that you can do. 1 mil is good, maybe less if the lymph node is small, depending on the size of the lymph node. But those size of lymph nodes and all of that, through the AI, it tells you exactly how much volume you can put inside them without causing that compression and necrosis. And then also you can, while you're doing the IV and you have access to the tumor, because those tumors most of the time, or if they are near to the skin, while ultrasound, you just put it there inside the tumor and squeeze it inside the tumor. I'm not saying fill it out too much with the pressure. Just if you can put 2 mil, 3 mil, and it's not just chemotherapy. You're going to put immunotherapy as well, and you're going to put some antifibrotic therapy as well. And if you put antifibrotic, immunotherapy, chemotherapy, along with all the systemic therapy that cause the tumor microenvironment to be hostile, which I can help you because all of this is being programmed in my AI because I wrote books under it. So when I give them anything, you just tell me, okay, this is how much you want to do. You do antifibrotic here. You don't do chemotherapy. This is the list of chemotherapy based on the RGC. You also the cancer stem cells. There's drugs specific for cancer stem cells, not like normal cells. And mebendazole is one of them. Ivermectin, it's also antifibrotic. Plus, it helps in the cancer stem cells. Methylene blue. Plus, there's other drugs for cancer stem cells. They will start telling you, okay, those drugs will help with interfering with cancer stem cells. These drugs will help to activate the mitochondria. So you have a complete list of drugs because of your medical AIs learning all those things, and it will now put and give you the dose and protocols and everything. And it's based on what you've been putting inside the AI and whatever data available throughout the whole data in the web and the internet, which is big data. They sum it and they give you all the references and why you are choosing those doses and those protocols based on this cases and this cases that everybody is putting it on the internet. So your AI is learning from all those publications and data, and give you the butter of what you're going to put. That's what I'm doing now with Dr. Canelli. She's already doing fractionate chemotherapy, and we want to upgrade it into platelet nanoparticle. She's already doing sonication after the chemotherapy, so we're gonna. I'm working on building a sonication with very unique specification to break down the fibrosis. Um, so we have the shock waves or that she has, but we need to adjust it where you have 1 million hertz and around 100 to 1,000 watts. And then based on the cancer location and depth and the consistency of the cancer, it tells you exactly what kind of watt and hertz you need to break the fibrosis or to break the tumor itself. As you know, FDA recently approved histotripsy. It's a sonication enough to even kill that cancer, and destroy that cancer. It's very powerful. That system costs 1.5 million. The treatment insurance reimburse around 20,000 to 70,000 for the whole course. But it's sonication that breaks the cancer, but also it breaks the normal tissue as well. So it needs to be done right and focus it right and make sure it's in the cancer, not into normal tissue. And that's the reason we need some sonication where it has both this high intensity focus ultrasound, but also with a little bit lower power just to get rid of from the fibrosis, so we can use it as more frequent than the one that kills the cancer. And so if we do all of that, if you do immunotherapy, chemotherapy, and you optimize the health of the patient and you detox the body and you provide them with everything that helps to optimize that patient's detoxing and looking at his sex hormone and definitely optimize that and make sure you're not doing too much of the sex hormone where you increase the estrogens. Estrogens is proliferative, can cause more of the cancer. So progesterone is good. It's anti-proliferative, but estrogen is proliferative. And we know testosterone can convert to estrogens. So people say, oh, prostate cancer, I can give them testosterone because testosterone will not affect. No, make sure that the patient is not obese. If he's obese, the testosterone that you're going to give, yes, you cannot, we're not blaming the testosterone causing the prostate to grow, but it converts to estrogens, and estrogens will cause the prostate to go and make it worse. So you need to think smart. If the patient is obese and you give him testosterone, you say, I'm an integrative doctor. I don't want to, no, that's not true. The patient prostate will end up even more worse. So you need to consider all those progesterone and aromatase inhibitors, and you check his estrogens. And if this testosterone that you're giving is increasing their estrogens, yes, it will lead to a problem to their cancer. So make sure that you understand, what we are looking for. And but as long, when you optimize the patient's health and detox the body and looking for all this nutritional deficiency, and you target therapy the cancer, you're not really destroying your immune system with this cocktail of chemotherapy chosen by the big pharma. And everybody, okay, you have breast cancer, triple negative, then this is the cocktail of chemotherapy. Well, those cocktail of chemotherapy may work with 50% of the patient with breast cancer triple negative, but some of them, they will not work because they are insensitive. And actually, if you give a chemotherapy cocktail that they recommend by Big Pharma to a patient that is insensitive to those drugs, you speed the process of the death. So instead of dying in 1 year, they will die maybe in 3 months. So making sure that you test those chemosensitivity and you do it and you come up with personalized, we call it personalized oncology. I call it systems oncology, and you make sure that they are specific, sensitive to that disease. And also immunotherapy. Not all the immunotherapy will work. Some of them, they don't have the PD-L1, right? And so you need to test them and make sure they are, those immune therapy works for them or not. And we have RGC Lab and many others that they test it. So we have better success in prolonging the patient's life than the mainstream medicine oncology. The mainstream medicine oncology, they have the caps, we don't. And there is a hope if we do everything that we recommend, which I don't see anybody's doing except few that I know, but still not complete. We're hoping that we're going to create that flagship where we do everything that I'm just talking to you right now and come up with data, because I see some doctors are asking me in the chat room in CDPM about the data from patients and testimonies and all that stuff. I have some Dr. Patel Kalpana and Dr. Michael Carfield, Dr. Weber from Germany. They all using the same thing that I'm talking here, although it's not 100%. They are into the 80%, and I'm hoping we can come up with the 100% where it's everything that we're talking here. But they almost, like Dr. Weber, almost 80% of what I'm talking about is implemented on patients. But even if you miss the 20%, it's still a problem, because cancer is like an onions with many layers. Is it enough to remove the 80% of the layers and say I win the cancer? No. In order to win the cancer, you need to get rid from the 100% of the layers, because if anything left, the cancer can grow and survive. Like in my case of my dad, when he has hypopharyngeal carcinoma, we did the photodynamic therapy, methylene blue, ICG, low dose chemotherapy. We did the radiotherapy. We did everything, right? And it shrinked, but it shrinked into, let's say, into a size of maybe 30 millimeter, right? And you can see it in his throat, 30 millimeter only, and the PET scan, right? But it's fibrotic and white. And before, when we put methylene blue, it's stained. Now, if you put methylene blue, it does not stain. Okay. So what is that? The fibrotic white tumor. That's fibrosis. The tumor is hiding inside the fibrosis, and it's hiding, and it's kind of protecting itself in a cocoon from the chemotherapy and the radiotherapy whenever you think, because everything is not going to be effective. They shrink to that size, and you think you're winning. Oh gosh, I win. I shrink the tumor from whatever to this small size, and it's just a small size. But that small size, if you don't get rid from it, right, it will grow like crazy, and we will be fooled by cancer. So they shrink, and it's fibrotic, but still there's cancer stem cells, which behave like normal cells. And this fibrosis squeeze the blood vessels, preventing chemotherapy from going in, from even immunotherapy, and from immune system to go in. And they stay in that side when you are over from chemotherapy, radiotherapy, and all that stuff, and the cancer feels safe. There's no stressors anymore. Those cancer stem cells will start growing and growing faster and become resistant to everything you put. And they become so aggressive after that. And in few months, it's stage 4. Right? From that little nut there. And so cancer is not enough to peel just 80% of the layers of the onions. You have to peel all of them. And we're going to learn all the layers. The layers of the cancer is fibrosis, is acidosis, is cancer stem cells. It's suppressing the immune system and pushing it to Tregs and Th17 and decrease the cytotoxic T cells and natural killer cells. It's inactivating the mitochondria and the mitophagy. It's the blood vessels become kinky, and where they don't allow the red blood cells from going in because they're kinked. They allow only the glucose to go in, and the cancer can adapt. If you think, oh, yeah, I deprive them from sugar and they will die, no, they will adapt. They can adapt, and they can even eat keto bodies, and they can adapt with lactic acidosis and aerobic respiration, and they still can survive. So don't be fooled by just saying, oh, just lowering the sugar will be enough. Those cancers can adapt even with lower sugar, and they can survive the hypoxic environment. But they favor that, and they can eat amino acids. All right, you think you deprive me from sugar. Now I'm going to go ahead and send chemicals in your body to degrade your muscles and get amino acids, and I will be feed by amino acids, right? So cancer, it's not easy. It's intelligent creature. They adapt about everything, and you need to be smart and hit it from all different directions and peel all the layers that we're gonna see here. So the whole purpose of this lecture here is to show you that the mainstream medicine conventional therapy, they fail because they focus on a single target and they ignore the systemic interaction, and they focus on killing the cancer and killing the cancer by interfering with the molecular pathway. Okay, this pathway, we're going to interfere with it by these chemicals, right? Whether we're going to intercept the DNA replication, or we intercept the folic acid, the methylation, or we're going to intercept. So they will intercept things that involve in the proliferation of the cells. Or we generate free radicals, right? So they will interfere with those pathways of the cancer, and that's what which is called the chemical pathway. That's and targeting on killing the cancer, whether by chemically or by radiotherapy, and recently they come up with immunotherapy. But think about that. If the cancer has cancer-shaped fibrosis, which is tumor microenvironment, and they squeeze the blood vessels, so your chemotherapy will not work because it cannot go into the site of cancer. Your blood vessels will be squeezed. Even chemotherapy cannot go in. And then the red blood cells will not go in carrying oxygen, so that cancer will be hypoxic. So whatever chemotherapy that you are thinking will increase the free radicals, there is no oxygen to increase the free radicals in the beginning because your blood vessels squeeze. So your chemotherapy will not work. And radiotherapy relies on oxygen because radiotherapy works by, yes, it causes mutations, but eventually those mutations generate free radicals, and those free radicals induce apoptosis. There is no oxygen to cause for the radiotherapy to work. So all of this is going to fail if you don't think about the tumor microenvironment. Important. Even if you say, oh, I'm going to give immunotherapy. Okay, like Dr. Soon Patrick, I'm going to give them cytokine interleukin 15 to activate the natural killer cells. Okay, smart. So you activate the natural killer cells. That's good. But your antibodies will not get into the immune systems. They will not get into the tumor because the blood vessel is being squeezed. So your antibodies will not get into deeper inside the tumor to activate the natural killer cells inside the tumor, right? Because that's what you're doing. You want to activate the natural killer cells, or the natural killer cells itself that you've been activated. Okay, smart. I will activate the natural killer cells in the lymph nodes and in the blood, so they will increase them, so they will kill the cancer. Well, your blood vessels is being squeezed by the fibrosis, preventing the natural killer cells from going in. So your interleukin 15 will not work unless you think, oh, so the fibrosis needs to be broken. Those cancer-shaped fibrosis need to be broken. Your blood vessels needs to be normalized. Your acidosis needs to be normalized because acidosis leads to shifting the immune system to Treg, and then your cancer become immune tolerance. So you need to consider all of that in order for your interleukin 15 that Dr. Stone Patrick is saying, oh, I solved the problem of cancer. The oncologists, they focus on killing the cancer by chemotherapy, but that's wrong. We need to enhance the immune system, and and let the immune system destroy the cancer. Yeah, that's right. But even your antibodies and your natural killer cells will not go inside. Even the CAR T cells, whatever they engineering T cells, and they putting antibodies on it to get rid from those cancer, those CAR T cells. But those CAR T cells will not go inside the cancer and kill the cancer because the cancer protect itself, form a wall that prevent those immune cells to go in. And so us now here in this room, all those doctors, now you understand the challenge, right? In order to win the battle, you need to understand the enemies, their tricks, and then you need to find a way to overcome the tricks. So the oncologists, the conventional fail because they are focusing on killing the cancer without thinking about the tumor microenvironment, specifically cancer-associated fibrosis. They are not thinking about the metabolism of the cancer, that they depend on sugar, yes, in the beginning, but they can adapt, by the way. But we can start with that. Yes, they rely on sugar a lot. That's why when you do PET scan, you will see that they are shining light because of concentration of those radioactive glucose inside the tumor versus the normal tissue. So yes, depriving them from sugar and lowering the insulin, because insulin is the cancer driver. So as much as you can lower it, it's good. And doing everything that helps to increase insulin sensitivity will help to treat cancer. Fibrosis is a top reason of failing in managing cancer, not just for mainstream medicine, but also integrative oncology. Hypoxia, because of the fibrosis, squeeze the blood vessels, preventing red blood cells from going in, carrying oxygen. You end up with hypoxia. Abnormal vasculature, and that's why we use Avastin, like Dr. Kamal is saying, to normalize those blood vessels because they have too much of vascular endothelial growth factors that leads to this abnormal, leaky, kinky blood vessels. They are a large amount, and think, well, it's highly vascular tumor, so how they have no oxygen? They're highly vascular, but they're kinked. What's that mean? Highly vascular and kinked, they will allow the glucose to go in, but they will not allow the red blood cells carrying oxygen to go in. So they end up with hypoxia. Yes, they're having nutrition going in, which is the sugar, but they prevent the chemotherapy from going in. And so that's mean if you see a cancer, say, oh, high vascular, how come it's hypoxic? Yeah, they're high vascular but hypoxic because of they're kinked and they don't allow red blood cells to go in. And then you will think, oh, if the problem is that if the hypoxia is due to red blood cells cannot carry the oxygen to the tumor, then can we increase the oxygen going to the cancer without relying on red blood cells carrying them to in? Yes. And that's the reason why ozone and oxygen chamber works. Because now you are forcing and dissolving the oxygen, not necessarily in the red blood cells carrying, but inside the plasma. Yeah. That way you bypass the need of red blood cells because you're increasing the plasma concentration of the oxygen. And that may help to bypass that problem, which is the squeezing of the blood vessel, preventing red blood cells from going in, carrying the red blood cell oxygen in. So, as ozone, it did help. And so, those oncologists, when you tell them, hey, a patient taking chemotherapy with ozone and oxygen chamber is better, they don't know why, right? Why are you saying that? I mean, and they actually they don't want you to do anything integratively to the patient while they're taking chemotherapy. In their mind, this will interfere the killing effect of the cancer. And there's some true about it, especially giving too much of antioxidants. It will neutralize the free radicals of the chemotherapy, radiotherapy that they are putting, but not ozone and not oxygen chamber. Those oxygen chamber and ozone, it does help to enhance the efficacy of radiotherapy and chemotherapy, but it requires some sort of education for the oncologists to understand it. They are not dumb doctors. They understand it. Just you need to approach them right with mechanism understanding, in chemistry, it's a language that all the doctors agree with. And I think that's one of the things for INTP like me, I challenge doctors with chemistry. And because that is the language that we can agree with. But I cannot just say, oh, it works. Okay, but how? If you don't explain how and the chemistry behind it, the oncologist will block you immediately and they say, you know, you don't have evidence. You don't have clinical trials. There's two evidence here when you talk to a doctor. There's the clinical trials, which is basically patients are trying it and then case and numbers, which is Dr. Peter Makara is very good in that. I mean, he's the top when he talks about studies and epidemiology because he got a PhD or master degree in and he's a epidemiologist. I'm not that much of clinical cases. I'm more into chemistry. So there's also chemistry and mechanism of action. That's my strength. I'm not good with studies when I bring my evidence. I bring my evidence mainly with chemistry. Now, which is more powerful? Both. If they have both clinical and chemistry, that's even better. But you start with chemistry because if you say epidemiology and you say a study in Iran or study in Egypt or study in Europe, the American doctors say, "Oh, I don't recognize," or South America, "Oh, I don't recognize those studies. Those studies, I don't recognize them. It has to be here in the United States and FDA approved." And that's what's the challenge. All an ivermectin story. The challenge was the epidemiologist of the doctors here in the United States, they don't recognize any studies that's outside the FDA, the USA, with the big pharma funding it. And nobody's going to fund repurposed drugs. And so there will be no studies really. And so when we manage cancer, we need to look at the tumor microenvironment, which include also the immune system, and the immune has to be balanced. And the cancer is so smart, the cancer. You know what they do? They say, okay, what kills us is cytotoxic T cells and natural killer cells. Right? So what we will do, we will go ahead and exhaust the immune system and secrete chemicals that will polarize the immune system to Treg and Th17 and Th2. And it's inflammation. Yes. Okay. Well, but and we suppress cytotoxic T cells. So there will be inflammation in the cancer, but inflammation that does not kill the cancer. Inflammation of the Th17 mediated inflammation. Do you know what Th17 mediated inflammation is for? They help to produce neutrophils. Neutrophils will kill bacteria because they will produce antibodies and neutrophils and antibodies, and especially with Th2, but it will not give you a cytotoxic T cells. So you exhausting your immune system for producing neutrophils and producing antibodies, and those neutrophils antibodies will not touch the cancer. But that's kind of way that the cancer cells is doing is exhausting immune system for inflammation that is not going to kill the cancer. In fact, it will help them to spread. And what chemicals that the cancer is secreting? All those chemicals, which is vascular endothelial growth factor, one of them that helps to polarize the immune system to Treg and Th17. All those chemicals, cytokines that they produce, the cancer produce, is really pushing the immune system into the Th17 Treg inflammation, which does not affect and suppress the cytotoxic T cells. So that immune dysregulation designed by the cancer to survive and conquer and replace the healthy tissue, that needs to be balanced. And how you balance it? By inhibiting the Th17, inhibiting the Tregs, and stimulating cytotoxic T cells. So what things that helps to inhibit? The thymosin alpha is a good one that blocks the Th17 and promote the Th1. So I give them thymosin alpha. I give them ivermectin, does help to inhibit Th17. Matlam blue and have the Th17. And then for the cancer cells, stem cells, I give them mebendazole. And then I will give also all the chemotherapy. And I will enhance the immune system as well with immunotherapy. Anti-PD-L1, anti-CTL4 does help the immune system to be polarized into Th1 and cytotoxic T cells because they block the cancer when they react with the natural, with the T cells, they turn them into Tregs. And that's mean they become immune tolerant. To block that, the PD1, PDL interaction, I give them antibodies that block them to prevent the cancer cells from turning the T cells into Tregs. And then they will become what? They become cytotoxic T cells. And instead of becoming T cells, and those cytotoxic T cells will start eating those cancer. So you need to understand that the cancers is like an onions with many layers. Their immune system needs to be modulated. The vasculature needs to be normalized. The fibrosis you need to get rid from it. And forgiving, how you get rid from the fibrosis? There's antifibrotic drugs. Losartan is one of them. There are many others. Lumbokinase, bromelain, things that breaks sonication. All of this helps to break down the fibrosis as much as you can. Methylene blue does help as well. And you need to get when there's many other drugs of antifibrotic drugs we can use. And so if you start, targeting all those layers and peeling all those onions, eventually you will be, and then you're also giving all those. If there's any chemotherapy that will interfere the pathway in low dose and nanoparticle, yes, and sensitive to that cancer, you use all the weapons you have. Whether it's coming from the mainstream medicine, integrative medicine, repurposed drug, doesn't matter. If it's sensitive and it works, just put it and use it smart, like a smart bombs. Difference between smart bombs and those dummy bombs. We don't want to do the dummy bombs anymore. We want smart bombs that kills the cancer and turn the tumor and microenvironment to become a hostile environment. And if you see here this lady, which is 56 years old, female, presenting with progressive fatigue and intentional weight loss, abdominal discomfort, and we examine her. She has hepatomegaly. She's stage 4, right? It seems like she has pancreatic tumor metastasized in the liver and lymph nodes. And you see that she has inflammation. Inflammation that she has is not the inflammation that helps to kill the cancer. It's the inflammation of Th17, which does not help. And then you have any other toxins, like she may have some, maybe the patient has some heavy metals or Lyme disease, anything that increase the immune exhaustion. It will definitely lead to the cancer to grow and proliferate, right? So you need to get rid from all those factors that exhaust your immune system, underlying inflammation, infection, all this needs to be getting rid. And you need to suppress that bad inflammation that the cancer itself is producing by giving thymosin alpha or all those drugs that we know it helps in decreasing and modulate the immune system. Um, and if you see those patients also, the reason they already have cancer, possibly because they have high insulin resistance as a driver for their cancer, driver that triggered the cancer. And also, if you're diabetic, you're actually causing more of those cancers to grow. And so you will monitor all this with all this biological markers of the cancer, and you start giving the treatments, right? And you're giving all the treatments to kill the cancer, to change the tumor microenvironment, but also optimize the whole system of the body. And if you do that, then you can win the cancer. So it's not just enough to kill the cancer. You need to look at all the tumor microenvironment, and optimize the health and strengthen your immune system, and looking for any underlying inflammation, chronic infection, heavy metals, leaky gut, whatever. All of this needs to be fixed because the cancer is not just genetic mutation, or it's not just driven by insulin. It's a combination of all those factors that leads to the cancer to grow, and we need to manage it all together and make the tumor microenvironment to be a hostile environment, not a favorable environment for the cancer, that what the cancer is promoting. And if you do that, then you kill the cancer. So the cancer, you need to fix the immune system, polarize the immune system to cytotoxic T cells. You need to fix the metabolism, making sure that you lower the insulin and you lower the sugar, and you optimize the body, you decrease the cholesterol. If there's atherosclerosis, you need to decrease it because you need the perfusion to the tissue to be normalized. If there's any underlying infection, any underlying disease needs to be managed. Any nutritional deficiency needs to be fixed. So it's all of it. It's not just genetic mutation, but it's a combination of genetic mutation and environmental triggers. And all of this needs to be fixed. Otherwise, those cancer will grow, or patient it doesn't have the cancer, but has all the drivers that leads to cancer, high insulin, toxic burden, chronic inflammation, chronic infection. All of this can compromise the immune system, compromise the immune surveillance, and even if you have genetic mutation, but if your immune surveillance is strong, you will not have the cancer. But if it's being compromised by all this environmental factor and you have that little mutation there, then your cancer will emerge. Even after you patients heal from cancer and has remission, right? But remission does not mean it's cure. Remission, they still have the genetic mutation. Now they're waiting for that environment to trigger that. So if you don't constantly be on top of all the tumor microenvironment factor that trigger that cancer to grow, then what will happen? The patient will have recurrence. So if patient has remission, in order to maintain the remission, the patient has to be on high polyphenols. The patient has to sleep good. The patient has to be eating healthy nutrition, lowering the toxins intake. All the food that she's taking needs to be healthy because she has the genetic mutation. It's like it needs that environment to trigger the whole thing, the bad environment. But if she's end up that patient with remission having stress, having high cortisol, lack of sleep, food is junk, right? Then there is a chance that those tissue will end up having cancer. So let's say a patient has colon cancer. And he said, okay, I removed, did resection of the cancer. The patient is completely remission. Good, but you did not remove the whole colon. And the colon, the normal tissue right now, do have genetic mutation of the cancer. And if you don't really maintain the remission by making sure the environments will not trigger those mutation in those normal tissue, then this patient will end up having remission, having cancer coming out from somewhere, right? From the normal tissue, and because they have genetic mutation. So then the cancer is not just genetic mutation, it is also environmental factors. And we can win the cancer. We cannot really change mostly the genetic mutations, although we can decrease the increase of those genetic mutations, which is caused by inflammation, which may trigger the cancer. Chronic inflammation leads to cancer because it will lead to more mutation where will trigger that and leads to cancer, right? But if we fix the environment and the patient is eating healthy, the immune is surveillance is strong, the patient is sleeping well, all the toxins being taken care of, patient is on high polyphenols and all that stuff, and low sugar, because insulin is a drive of cancer. Let's say a patient is in remission and he's eating sugar, all right, and his insulin is high. The insulin will stimulate the mTOR, and she has genetic SNPs of cancer. Oh, she will end up with mutation. So once they get into remission, they need to live the life to make sure their environment, it's not that hard, right? Once they understand the healthy food, the low carb, the polyphenols rich, all those avoiding of all those toxins that's coming from our drink and food and all that stuff, and picking up the right food, then we can definitely prevent that recurrency from happening. Okay, so cancer must be understood as a system before it can be treated as one, right? So we know the cancer is not just genetic mutation, or it is also systemic problem. And when we manage the cancer, you cannot just manage it from just the cancer and removing it, resection and all that. You need to manage the whole systems of the body. If there's leaky gut, if there's a diabetic, if the patient has allergy, if the patient has toxins, if the patient has infection, all of this needs to be fixed to prevent that recurrency from happening, and to prevent the triggers of that mutated or SNPs that leads to cancer. And so at the end of the day, the cancer is a combination of metabolic, immune, genetic, and tumor microenvironment, and the whole system of the body. And so if there's genetic SNPs plus bad environment, then you will have cancer. If you have genetic SNPs and the environment's being fixed, then the risk of cancer is going to be low. If you don't have genetic SNPs of cancer and you have bad environment, there's a risk you're going to have cancer. So the optimal is that you have no genetic SNPs of cancer and you have good environment. You're fixing your environment. That's the best thing. But if you're genetic SNPs, then you need to fix the environment. And if you don't have a genetic SNPs and you have bad environment, which I'm talking about, you're eating junk food, your sugar is high, your insulin is high, insulin itself will stimulate mTOR and can lead to cancer, even without genetic SNPs. And so that's the reason, people say, I'm smoking for many years and I didn't have cancer. Another guy, he did not smoke and have cancer. Well, lucky you that you smoke, your genetic SNPs are, you don't have genetic SNPs. And yes, you have bad environment, but it seems like you're so good, your genetics, which are able to detox all those toxins that you're giving. But that guy, he have genetic SNPs. And it's just a little change of the environment, bad environment, he end up having cancer. But think about if somebody had genetic SNPs and his environment is bad, whether he's the food that he's taking or infection or whatever, then yeah, that's a bad combination. This guy's gonna have cancer for no question about it. So either way, the best scenario is at least fix what we can do. We cannot really change the genetic SNPs unless we start doing this genetic cutting those genetics. There is some monogenetic disease that they cut that genetics and then replace it. They have a name, but I forgot the name of it. It's a terminology they use it. But we there's some disease which is just one genes. They with one of the genetic of eye disease, they come up with some trials and it's working. But we cannot do it for if the patient has many genetic SNPs. We cannot fix it by we don't have the technology yet to change your genetic SNPs, right? But we can help to if we know the genetic SNPs and what that genetic SNPs leads to. Let's say abnormal metabolism leads vitamin D or abnormal metabolism of B12 or abnormal metabolism of certain thing, we may be able to come up with some supplements and increasing the vitamins and all that to overcome those SNPs. Or genetic mutations in the detox. So maybe the patients may need more of antioxidants and detox and chelations and avoiding of those environmental toxins because he has genetic SNPs and detoxing. So there is, if you give me those genetic SNPs, we put it in the AI, they can read it and they can tell you, okay, this is the supplements that you're going to do, this is the things that you're going to avoid, this is the lifestyle you're going to live in order to compensate for your abnormal genetic SNPs. That's what we do when we do nutritional genomics or we do treatment based on genetic SNPs. And they would direct what exactly drugs you take, what supplement you take, like we did with chemotherapy. That's pharmacogenetics of cancer, or what drugs that works better than others because they metabolize certain drugs than others. Those are pharmacogenomics. And we know the nutritional genomics based on genomic SNPs. We can say, oh, this patient needs extra vitamin D and extra vitamin B12, whatever. He needs this lifestyle and all that stuff, sleep very well, needs more antioxidant. So the genetics studies, and I do recommend doctors, if they want to optimize the patient's health to the max, then they need to come up with protocol based on the genomics. But you don't do nutritional genomics as the first start and cost a lot of money on the patients before you do the basics. You need to do the basics first, which is lowering the insulin. And lowering the insulin by, start with low carb diet, with exercise, with increasing your muscles, right? Like what Dr. Stefan Hartman has. I like what he has. He's doing chronic disease prevention and management, but also he's doing it right. If you have a clinic, say I'm integrative clinic, and they don't have a gym, I don't think that clinic is really giving a good outcome. You need to have a clinic with a gym. That's why I reached out to Dr. Canelli and I said, you have this 30,000 square feet. We need to commit at least 5,000 square feet for a gym. All right. A clinical gym that's not just lifting weight and all that stuff and treadmill, No, those clinical graded gems, they have the cold plunging, the sauna, plus they have all the diagnostic testing to monitor the heart rate variability, your fat distribution, your muscle, your muscle strength, and all that stuff. So there is monitoring system, um, um, and also how much you are. Consuming oxygen per mass of your muscles, all of this. There's a monitoring that's called VOX, VOX, or VO2. Those are monitor systems to know whether you are performing and increasing the performance, not just optimizing the health, but also increasing the performance of the health. And that require that clinical gym inside the clinic. So I have Dr. Barr. She has only 2,000 square feet. And some reason she was able to stick in her clinic in one room a mini gym that does this exercise thing and also monitor the heart rate variability, the oxygen consumption, all of that, right? And that's very important. Why? Because in order to lower the insulin, it's not just low carb. You have to increase your muscles mass because they work like a sponge, absorb the sugar, and it helps to decrease insulin. Plus, the muscle itself, when it's big and you have muscles, it does help the patient with cancer. Why? Because the cancer produces lactic acid, right? And the lactic acid it causes this acid environment that suppresses the immune system and also cause fibrosis and that the fibrosis of the cancer. So if you're exercising and you're increasing the muscles, you getting rid from those excess of lactic acids. So muscle training and exercise is a treatment of cancer. So if you have a patient with cancer, you want to treat them, beside the things that we're talking about, they need to increase their muscle tone or muscle mass and their muscle strength because it does have an anti-cancer effect. Also, it secretes chemicals that kills the cancer. When you're exercising, you're secreting chemicals to kill the cancer, plus you're getting rid from those acidosis and the lactic acid that's produced by the cancer. And so, exercise, it's part of increasing the muscles, and this mini gym in the clinics. That's what I recommend for any doctor who is opening integrative medicine clinic. If he doesn't have a mini gym inside it, that integrative clinic is not going to perform as, for example, what Iman Bar is doing or what Dr. Stefan Hartman is doing in Florida, or what we are doing and going to do, hopefully, when I traveling to California, what we're going to have in Dr. Keneally Clinic. Any questions up to now? We good? Questions? Everybody's happy? Okay, so basically, all the slides that's coming up is going to repeat the things that we talked about. And you're going to see it in a very colorful here form. You know, they say, for example, why conventional oncology failed? Because they use single therapy. You know, if they use immune check inhibitors, those mainstream oncology, it's not going to be enough because even if you activate the immune system with your anti-PD-L1, anti-CTL4, anti-PD-1, right? Well, okay, you have powerful cytotoxic, you have very good, powerful natural killer cells, but your cancer is fibrotic and it's squeezing the blood vessels. It will not go in, right? And so just focusing on just killing the cancer is the reason why we fail. Those naked cytotoxic chemotherapy, the naked ones, goes everywhere, healthy and bad, and you get little really drug going to your cancer, and it toxicates the whole body. So really, that's the reason of the failure. So we need to consider doing targeted chemotherapy, which is loading a cyclase nanoparticle. So in general, the mainstream medicine failed because the treatment is static, it's not dynamic, right? Is not learning the tricks of the cancer and overcome those tricks. And us, what we're doing, we are actually working on learning all the tricks and overcome them, right? By changing the tumor microenvironment to make it hostile environment, by decreasing the acidosis, by breaking the fibrosis, by immune modulation, shifting it to Th1 and cytotoxic T cells. And if you do all of that and you open up the blood vessels and you're doing the ozone and all that stuff to help to oxygenate, and you're activating the mitochondria, giving them polyphenols, and you use the chemotherapy based on the sensitivity testing that's coming from RGC lab, for example, you get to create a cocktail. And you can still do radiotherapy, but it will be better if you do radiotherapy and you inject into the tumor or into IV some radiosensitive therapies, like indocyanine green. They are very sensitive. So when they accumulate in the cancer, or methylene blue, and you do radiotherapy, you can do even lower dose radiotherapy and still effective than just radiotherapy by itself. Or there's some chemotherapy that's radiosensitive, like cisplatin. And if you do all of that, then yes, we are able to look at all the failure. Why we fail? That's the question that mainstream medicine is not answering themselves. Why they are failing? They are failing, blaming, say, oh, the patient end up with mutation and he's resistant to the chemotherapy. That's part of it. Yes, the mutation can lead to change and they become insensitive. But then you need to look at what is sensitive to, and then you need to look at other things that leads to resistance of the chemotherapy, which is the fibrosis is the biggest part, right? Cancer stem cells. Those are resistance to chemotherapy, right? Then let's give medication to destroy the cancer stem cells. And there's less of medication that helps the cancer stem cells. So now you understand the cancer stem cells. It's also because of this fibrosis thing. And if you understand this dynamic, then you can have better solutions to treat the cancer. And how to reverse, once you change the tumor microenvironment from acidosis to alkaline, then you lead to reverse of cancer stem cells to become cancer cells. So you can reverse those cancer stem cells. They're cancer stem cells because they're inside the acid environment. But once you get rid from that environment, they will become cancer cells and they become sensitive to your treatments. So, or you give therapies that target the cancer stem cells. There's pathways specifically for cancer stem cells. So the ignoring the immune dysfunction, the metabolic disruption, the tumor microenvironment is the reason why those patients of mainstream medicine fail. Do integrative oncology? Yeah, integrative oncology, they did not completely succeed in managing cancer because they get excited to say, oh, the cancer is all metabolic. So all we need to do is just lowering the sugar and the patient metabolically, fix them metabolically, and that cancer is gone. Right? That's wrong. Right? And then it would be like, the mainstream medicine, they start laughing at us. That's not the case. But those people of integrative, they have one layer. They say, oh, I'm doing immunotherapy and I'm big, like Dr. Sun Patrick, and I am cytokine, interleukin 15, activate the natural killer cells. And we got rid from cancer. This is the solution. We answer the solution. So the problem with integrative oncology, they come up with one layer and they say this is the solution. Yes, it is part of the solution, but it's not the whole solution. The whole solution is to peel all the layers of the onions. Nothing will left. Okay. And if you find that I left anything, right? If I left anything in my management, then I'm not killing the cancer. I'm not really getting into their mission. And I cannot be excited because I still have the thing that you said is not being covered. And that's what I want to hear. I don't want to hear, oh, Dr. Halasa, you cover all the layers and we have the solution. Well, again, the cancer has tricks. And I'm not yet excited and happy till I find all the layers. And I am kind of teasing you, doctors, to come to me and say, Dr. Halasa, you covered this layers, but still you have a layer. I like that. Come and talk to me. But I'm not going to say to you, oh, I conquer the cancer. I cover all the layers. Cancer is just metabolic, immune, fibrosis, vascular, and that's it. And it could be more. Cancer stem cells could be more that I don't know. And so when I see those doctors are excited, just they say, "Oh, cancer is metabolic, has nothing to do with mutation," or "Cancer is immune." That's it. If you fix the immune, you're done. And really, they are just peeling one of the layer, and they got excited, they got the hype, but really, that's not the complete answer. So the focusing on tumor destruction without changing the tumor microenvironment, those patients would fail. Also, if they are focused on saying, "Oh, this is it, this is the solution, it's immunotherapy," like Dr. Soon Patrick, activate the natural killer cells and you get rid from the cancer. No, if you have the fibrosis, your natural killer cells will not go in, so it's not going to work. So you need to work on all the things, all the layers, in order to really kill the cancer and conquer the cancer. Also, it's not just like Dr. Canelli here. She'll say, "Okay, you think this is it? Well, there's more. If the patient is being stressed and he's not sleeping at night and has stress, emotional stress, and the cortisone is high, the cortisone will suppress the immune system, polarize the immune system away from cytotoxic T cells. So if you have high cortisone and epinephrine is high, even if you do everything, peel all the layers, and you don't take the care of the emotional and psychological part, you're failing." And I will say to Dr. Kennelly, which that she is very good in that, you are right. Part of the management of cancer is also the emotions and the whole thing. And so they need to be emotionally strengthened, especially if you emotionally strengthen them and you solve all the stressors, the psychological stressors. That's like almost 50% of the cancer. The reason, because there's something that's called oxytocin that will reset the whole physiological process of the body and empower your immune system to kill the cancer. And if I do everything and I miss the emotional and the psychological, and I say I conquered the cancer, trust me, I did not. I failed because I did not fix the psychological and emotional part of the patient. See, it's more than just physical. There's also spiritual and emotional and psychological. And I am a person who is very open-minded, and I will say yes. But if you say the cancer, I can treat it only by emotional and psychological and not doing the other things, I would say you may have some chances that will work, but it's not going to be for everything. And it's applied for everything. Oh, I have a case, and by metabolism, I fix the cancer patient. Yeah, you have 2 patients, 3 patients. I agree with you. It will work, but it will not work for everything. Oh, I fix it by immune system. Yes, it's 2 and 3, but it's not going to be all. I fix it with emotional. Yes, 1 and 2, but it's not going to be. But if we do everything, we have more chance to conquer the cancer than doing just one layer of the cancer. Okay, so any questions? I think we're good. I think the time is too much. It's like 9:30, and I think it's better for me to hear from you and have a discussion instead of going through the slides. I can get the slides available anytime you want, but let's get the people here. If you have any questions, Dr. Kamal, go ahead. Anybody raise his hand? Wants to talk? Questions? Are you sleeping, guys?
No, that was great class.
It's really interesting.
It's a lot to take in.
Right. And that's the reason it's better if we take a break and
Right.
see if there's any questions.
Well, Dr. Lass, it's high content in a short time, so a lot of times that needs to be gone over more than once.
Right, right.
Dr. Halasa, I have a
One
question.
question,
Oh, okay.
maybe a loaded question. Do you believe there's a difference, and or can the body tell the difference between a natural sugar, a fake sugar, and then a processed carbohydrate that turns into sugar?
Okay, so in general, I like balanced food and more anything that's coming from the nature. Now, I'm not talking about patient with cancer. I'm talking about prevention. For prevention of cancer, I would say it's okay to eat honey. It's okay to eat fruit and vegetables, but it has to be the whole thing and not processed extracted sugar by itself. Because let's say the honey does have sugar, but also it does have polyphenols.
Right.
And so the polyphenols will negate the problems of the sugar itself. But if you take sugar out of the canned sugar or from the sweet potato extraction, and you don't take the polyphenols with it, then you are increasing the insulin, and insulin stimulate the free radicals, and there's nothing to neutralize those free radicals that insulin is creating. We need some insulin. Insulin is sword with two edges. We still need insulins to stimulate the mTOR and stimulate the growth of the muscles and regenerative function. But we don't want the insulin to be constantly high. We need it to be like up and down. So when it's up, it stimulates the healthy cells. When it's down, it inhibits the mTOR and kills the bad cells. But if you can constantly eating sugar and generating free radicals and stimulating the mTOR constantly, then you also stimulating the bad cells to grow, which is cancer cells, inflammasome, senescent cells, and then you end up become sick. And so as long as you are eating natural food that's not being processed, extracted, then you are in a good shape.
I want to add this something to this, Dr. Halasa. So,
go ahead.
Joe,
I know I want you to be in California. I'm traveling there, so I told him about you. So think about from April 19 to May 17. You need to give me 2 days or 3 days where you can bring your program to my clinic there and see how we can turn it into something big.
Okay, good. I will do that. So, Joe, what do we make sugar with in America? Do you know?
It's not sugarcane no more.
No, it's not.
We
So
press
what do we
sugar
make?
beets. Sugar beets, right?
We make it from sugar beets, and sugar beets actually is a GMO. Now, most of the time when we talk about GMO, people have no clue what it means.
Right.
I ask people all the time in clinic, what does GMO mean? Oh, genetically modified. I say, then what? Genetically modified for what? So it's genetically modified to tolerate Roundup.
Right.
Now, the Roundup herbicide has glyphosate, and the glyphosate is highly estrogenic. So the problem is that the sugar that we see in the market, so if you go buy sugar, it says brown sugar, white sugar, raw sugar, white, they're all sugar beets. Next door to that sugar, they have cane sugar, and they have cane sugar organic. Then they give you coconut sugar organic. Now they give you monk fruit sugar, and they give you stevia. So those other four sugars probably better than sugar. The problem is when you go to a restaurant or you go to any place to buy cookies or things that they make sugar with, what type of sugar everybody is using?
Bleached sugar, right?
They're using the white sugar, which is the GMO sugar.
Correct.
Now, if a sugar is a GMO sugar, that means there's glyphosate in it.
Right.
And the glyphosate is toxic. So basically, it's a cancer. It can cause cancer because of the chemical itself. So if you're eating too much sugar, it will go and feed your cells and turn them into cancer cells.
Agreed.
Obviously, insulin plays a major role, but many of the chemicals that we have in our blood and urine that the CDC is measuring since 2001, they mimic estrogen. And those estrogens, they make insulin go up. That's why women, before their period, 3, 4, 5 days before the period, they crave sweets because at that point, the progesterone is way below the estrogen, so they become transiently estrogen dominant. So when they have too much estrogen, it makes the insulin go up. And when the insulin goes up, then they crave the sweet. And if they eat too many of the sugar-containing foods or carbohydrate in general, then the blood glucose goes up, and the insulin takes the excess glucose and puts it into fat cells.
Mm.
That's why since the mid-1990s, if you notice, obesity was going slowly. In 1997, it took up astronomically and has not come down. It's worldwide. Why is it worldwide? Because glyphosate or Roundup herbicide is the major herbicide used worldwide.
Right.
And that's why since 2025, according to the World Health Organization account, we should have 2.7 billion people overweight worldwide. So they're all connected. Now, when you talk about the other form of sugar like aspartame, sucralose, those are
Yeah.
fake sugar that they make.
Right.
They also contribute to the problem because they're fake sugar, and some of them cause dementia. So if you convert into formaldehyde and then it gives you dementia, formaldehyde is not.
Shoot. Did we lose you, Dr. Tano? You froze.
He needs to buy a new computer, Tano. Get you a new computer with better RAM.
Amen. Yes, he does.
Right.
He'll be on tomorrow where he's doing an
Dr.
estrogen.
Tano's still, connected.
No, he left. He's
He
coming back.
froze.
Just make sure you get him back, Shell.
Yeah,
I'll
definitely.
call him to come back.
He'll
Right.
be doing a hint. He's doing a speech.
He
And
speaks
Dr.
tomorrow with
Circle. Yes.
uh
Clearfield.
well
Yep.
get me a spot with Clearfields on those Tuesday. Not this
Will do.
Tuesday, but the ones that's coming up.
Will do.
So we can
So I
get
didn't hear.
systemic oncology. Okay, he's back.
Yeah, I'm back. I couldn't hear the answer, Joe. What? I'll ask you if this was clear.
Yeah, no, that was exactly clear. That was exactly that's what I thought was happening. I really did because just like Dr. Halasa said and Dr. Devlin when he was here at Dr. Clearfield's conference in Reno, he was saying the same thing. It's just not as easy as giving up sugar. That's no. It's the same thing with
Right.
smoking. You had a lot of the people that were smoking during COVID and they didn't catch COVID, and now you've got some of the muscle or the weightlifters and CEOs, CTOs, CFOs starting to use nicotine, but they're not smoking it and they're not eating it. They're taking it either in patch form or pill form now, and it's a different mechanism and it's more, I guess you would say, holistic, more natural, ironically. So it's the same thing with the sugars. There's just so many different sugars. It's ridiculous. And then when you get into man made stuff, it's definitely a chemical structure that's it's how the government patents things. The
Yeah.
same thing,
But
they
I know
that's
what
why
he's
they.
trying to say is that because to get rid from the insects,
Mhm.
they genetically modified the plant to
Right,
to sustain and live those sprays, because those sprays is toxic to the regular plant, but not the
right,
GMO. So
mm,
they come up with the plants that they can survive the glyphosate,
right,
and this glyphosate will kill the insects. But the problem then you have is those plants are contaminated and their products and extract with glyphosate, and the glyphosate itself is a free radical generator, is estrogen mimics. It will increase the cortisol and generate free radicals, and it's causing insulin resistance and it's causing insulin to be high, and eventually it's a carcinogenic at the end of the day, and
Correct.
inflammatory, and it will degenerate and cause all the cancer and cause the metabolic upset and all the problems that we have.
right.
And I think that's but what the solution is for us to do now, the solution is to get a piece of a land and try to grow the plant. And I think Methylam blue could be the answer. If you spray the plants with Methylam blue, it will attach to the bugs, and with the sun, and it possibly can kill them.
Got you.
So if we use something natural to the state of glyphosate to kill the bug and still the plant can survive, maybe that is the answer. But I'm just suggesting maybe Methylam blue or something equivalent that is photosensitive that may kill the bugs
Counter it.
and without causing damage.
And yeah, now even to make matters worse, the weeds are becoming resistant to glyphosate.
Right.
And because they're becoming resistant, now they're going to use 2,4-D, which is similar to Agent Orange, and they're going to mix that with the glyphosate, the Roundup, to be more potent to kill the weeds. Now, if they do that, then we're all dead because there's no way we can survive this chemical combination. Now, they're already using atrazine to kill the weeds, and atrazine is an aromatase booster. The problem is with the aromatase, it converts the testosterone to estrogen. So if you convert the testosterone to be estrogen, and that's why many young boys now, they're having breasts, they're growing boobs. You wonder why so many kids are having breasts, because they're eating all of those food in school. For instance, the school lunch that everybody eats is all toxic. If you visit a prison and you look at the prisoners, if someone goes to prison, within 3 months, they grew breasts already. You wonder why, because they're giving them these foods that are toxic. So the toxins are what is driving the chronic diseases, including cancer, if you ask me. So tomorrow, the precursor of what we're going to talk about tomorrow, which is the estrogen. That's why I personally don't give any estradiol to anybody, because people think if a woman is menopausal, she's going to have brittle bones, she's going to have that. So let's give them estrogen. So they put them on estradiol, not knowing that the estradiol and the estrone interconvert. And the conversion of the estradiol to estrone is stronger. It's stronger because the beta steroid hydrogenase that converts the estradiol to be estrone is stronger than the number one. So there are two of these enzymes that do the conversion. So if you're converting your estradiol to estrone, and estrone converts into 2-hydroxyestrone and 16-alpha hydroxyestrone, the 16-alpha is involved in cancer production. So you will generate a lot of cancer by giving the estradiol. But now some people say, oh, it doesn't matter. Men can have as much estradiol as they want. And they're giving them all this testosterone adjuvant stuff, and they're not looking at the amount of estradiol these men are making. They don't care because they say, oh, it doesn't matter how much estradiol they're making. It matters because this estradiol can actually cause them to have prostate cancer and other cancer, lung cancer, colon cancer that many men are having. So you wonder, what are we doing? I really don't think that we have a consensus on the estrogens, because people are not taking into account the environmental estrogen that are thousands and thousands of them that are driving the insulin resistance, that is driving the cancer.
Right. Wow. There's another question from Dr. Stock with CME achievement mechanism.
That's for Dr. Halasa.
What is that? What the question?
There he is.
What's the CME achievement? Is that one?
Yeah, what's the mechanism for achieving CME?
I was doing CME, and then the company has some glitches, but I may end up having something next month. But I do have a lot of courses in YouTube recorded in the past that has CME. Just watch it, and there's a link And I will send you, if you text me, I'll send you that link so you can obtain from the previous CME. For this one, you need to wait till we have solved this problem. I have some company reaching out to get the CME going, but I have a lot of CME for previous lectures, including Dr. Teno himself, and I will recommend you to look at it. So my phone number is 713-291-6123, and I'll send you the link of the YouTube where you can get a lot of CME from previous lectures. And some of them are similar to this one. Well, I apologize for not having the CME for today. I'm working on it to get it soon activated. Any other questions? Everybody's happy? Happy Easter, and see you Monday.
I was going to, no, don't go yet. I was going to ask
Go
you,
ahead.
so currently, for me, to cure cancer, we have to go way back to the root cause of the cancer, meaning the toxin that we have put in our environment. Because we cannot actually clean up the toxins themselves, the farmers are reluctant doing that. They're not willing to give us good food.
Right.
Like Dr. Halasa said, maybe we should grow our own food and use methylene blue on it. That is too complicated. So now what people are doing is a therapeutic plasma exchange, which I think is going to be the therapy of tomorrow for people who actually want to get rid of the toxins that are driving the cancers and their chronic diseases.
Right.
So if they do therapeutic plasma exchange, they can clean up their blood, and therefore they can clean up those toxins. And if you have no toxins in you and you're eating clean, at least you're not inoculating yourself, then probably the probability of developing this cancer is going to be low. Otherwise, everybody who lives in this country or even abroad, not only this country alone, but worldwide, is more likely going to get cancer, somehow, some form of it.
Agree.
Yep.
Yep.
Hey, hello everybody. I enjoyed that. Thank you, everybody. Hey, and I just that I want to admit some ignorance, and because I just found out when I was at Costco getting my food, that organic considers the inclusion of GMO, non-GMO. Okay, so they with the word organic, which is what most people are using, they have unified the GMO issue with the pesticides and herbicides. So now you can if it says organic, it can't be GMO.
Correct.
Well, they've joined the two when they should be separated and looked at individually, especially because of what you're talking about with the glyphosate.
Right.
Okay, it's kind of hides in the thing going on.
Yeah. So organic. When it says organic, so you have to pay attention. If it says just organic on any product, it means only 2/3 organic. That means the farmers are allowed to use a certain amount of chemicals to produce the food. But if it says 100% USDA, 100% organic, that is organic. Right. And they have to pay a lot of money to certify USDA 100% organic. So people who cannot afford that amount of money, some of them don't even put anything on it. They say, well, it is like for eggs, they will say it's free range, etc. But it doesn't mean it's completely organic. They give them grains that are not organic. So it's a very convoluted and difficult to understand the whole nomenclature of what we call organic. Because
yeah, well, you're making it clear. I appreciate that. Thank you.
Sure.
But there is plant-based pesticide, like coming from the capsaicin, garlic, coming from neem oil. Um, there's many way really to come up with natural pesticide and grow plants in with the free uh, glyphosides and all these toxins. And I think that's what the future we may consider, that if really we want to live healthy and have quality of life.
I'm going to throw some more in there because I can't keep quiet anymore. So the fact is the healthier the soil is, the less you need insecticide. That's a fact. And if you also you can go by the taste. If you're buying fresh vegetables, they should taste good. They should taste like they're supposed to taste. And if
They
they
have a
don't,
nice aroma. It smells
yeah,
good too.
yes, yes. And the thing is that when they first started with the organic foods, they didn't taste that much better because they had a long ways to go to get their soil healthy again. But more and more often, I'm finding that the food is tasting better. I think that the long term, the length of time that we've been doing it. And by the way, please don't think of it as expensive because it's so much
Right.
cheaper not to be healthy than it is to be sick.
Oh, actually,
So,
Mary, actually, you're correct about that. That the patient sometimes I see, I get a little bit of pushback from the patient. Oh,
yeah.
he told me to go eat organic food. I'm poor. I don't have the money, etc. But these same people that come into the office with Louis Vuitton. So I call
But
it
they'll
the
still have their cart full of
yeah,
potato chips and Fritos and
I call it
crap.
the the Louis Vuitton paradox. Louis Vuitton. So you have a beautiful bag, you cannot afford organic food, you're gonna cause trouble for yourself, but yet you just carry this beautiful bag around and show off what you have, and you cannot afford good food. It's
Yeah,
contradictory or contradiction to what we call good health. And
yeah.
they're blaming me for telling them the truth, which is the problem. I don't understand that.
And it's a lot cheaper to shop 2 or 3 aisles than it is to shop the whole poison store.
Yeah.
So,
And there's also, I'd like to point out, you have co-ops now that are sprouting up
yeah.
throughout America. And the co-op we have here in Reno is around 150 to 200 miles circumference. And so what they do is they go anywhere from from here all the way to a couple hundred miles to go certify what they're using on the farms slash ranches, because like you said, Dr. Tano, I believe the beginning stages of organic certification is like $50,000 for your
Yeah, it's
basic
very expensive.
certification.
Very expensive. Yeah.
It's super corrupt. And so now they're breaking away from these type of systems, kind of like medical, the same thing a lot of us are doing, a lot of medical groups. So that is available and it's getting a lot better. And, it's like nowadays it's hard to find fruit with the seeds in it. It's crazy how they have genetically altered that system. And so it's people understand this, and even the rich people are starting to get sick. So everybody's starting to get sick. So we're doing our best to revert back. But like you said, it, until then, we have to learn to detox in a huge, in essence, a fast way. And you can't just do red light. You can't just do
Right.
sauna. It's a little combination of all the above.
Correct.
So we got this.
I think it's sad but
So
true what Dr. Tano said that the future could be in plasmapheresis.
Agree.
correct. Yeah.
Well,
Plasma
the
exchange.
cheaper part, I did apheresis. I went to Germany and I saw this
Mm,
just, I spent 3 days there. I was training them to do loading drugs inside platelets nanoparticle, but they do apheresis, which is a
mm,
machine. It has a filter and it filters, but that filter does not really filter those nanoplastic. Maybe they cut
right.
some, but still it's there in the blood. I think the future, and then we in Dr. Joseph, we did the plasma discard, which we take the blood centrifusion, get rid from the plasma, return the red blood cells, right? But I think the best and more affordable thing is just go ahead with phlebotomy and get rid from 500 ml of blood every month for 1 year. That may help to get rid from everything, and it's more affordable, more cheap than plasmapheresis and plasma discard. Both
But
of them cost.
that's even a little bit controversial, because if you donate blood, right, and that blood is going to somebody else, and that blood is contaminated already.
No, you throw it away. No, you take the
Okay.
500 mil and you throw it away.
And they throw it away. Okay, all right. But
Yeah,
because
and
people
then
donate blood, and they,
what I meant is that just throw it away for that patient who has autoimmune or severe allergies or toxins. If they just get rid from 500 mil every month, in 1 year, possibly they can get a lot of their toxins out of their
well,
system.
that's a big
Agreed.
problem. One of the biggest problem is iron deficiency. You
What is
know,
that?
since iron deficiency, since the mid 1990s, 1997, if you look at iron deficiency anemia, it has gone up astronomically. So if you want to do phlebotomy and try to reduce toxin load by doing that every now and then,
No, just every once a month, 500 mil, and then
even
you
that,
eat good and you take some iron if that needs
yeah,
it.
if you take
Right.
iron, maybe it would be good. But if you
Yeah,
don't take
no,
iron and do
good
stuff,
food, grapes, and all the
yeah,
food that's rich with iron. 500 per month is not a big deal. And
Right.
if you see in the past, in the time where people in the nature and the wild and then the war, they cut themselves every day
Right.
and they bleed. I mean, I don't see much of blood or bleeding anymore from this life that we live. So I think getting rid from 500 per mil of blood, especially if they're heavily toxic, especially with this environmental toxins. And then after that, you make sure you avoid eating all those toxins. Because if you get
Right.
rid from 500 and still eating toxins,
the toxin,
junky
yeah.
food, you're not accomplished. So you make sure you're free from plastics as much as we can, but it's going to be difficult. Our clothes is plastic. The furniture is
Right.
plastic. You're
Right.
you're we're living inside a bubble of petrochemicals. Unless you live the life of the Amish and just do cotton clothes and wood,
Right.
and you don't touch any free microplastic in your household. It's gonna be difficult. The life that we live is petrochemical.
And that'd be a nice research project, believe it or not, is the Amish, because they may be doing what they're doing on their farms and they be out with their horses and their carriages, but the cars are driving by them. And Stephanie Sanoff and others have started to test the freeways and the roadways for the glyphosate in the air because of the ethanol that's not only genetically modified and sprayed at the same time, but it's sprayed throughout its life and it's grown throughout its life. So you've got these multiple systemic routes of glyphosate now being burnt even in the field. So it's now in the air. So I'm sure they're getting poisoned too. It's very hard to escape it completely.
Actually, I lived in Wisconsin for a while, and I used to go to the Amish farm in Organic Valley. So when you go to the grocery store, and
Your voice is low, Teno. Get
We
your
can't
voice
hear you,
high.
Dr. Tano.
okay, do you hear me now?
Yes.
There we go.
Yeah.
I said I lived in Wisconsin, and I used to go to the Organic Valley. So when you go to the grocery store and you look on the milk, it says Organic Valley. So I know exactly what that is. And it's the Amish people who produce that milk, and they sell it to the Organic Valley that makes the milk that we see in the grocery stores. So
Okay.
it's a 40 miles out. We go there and buy the food. But like Joe said, if the glyphosate is evaporating and it's going up in the air, and it comes back as rain, the rain
Right.
does not discriminate. The rain is going
Soil.
to go on all the crops, even though we think it's organic.
Exactly.
Still, that crop is contaminated somehow with glyphosate. So that's why all of you should do the glyphosate detox. The glyphosate detox by Dr. Isaac Elias. He has eco-nugenics. I don't know if you know eco-nugenics. And he said the glyphosate detox, to detoxify the glyphosate. And that's the only place I have seen. I don't know any other person who is doing a detoxification of a glyphosate. A lot
How'd
of
you spell
people,
his last name? Isaac what?
Isaac Elias.
Oh, okay.
Yeah. So eco-nugenics. So if you go to that website, econugenics.com,
Okay.
he said the glyphosate detox.
And I'm sure Dr. Senef has a process to.
Stephanie Senef, I don't know. She talked about glyphosate a lot, but I don't. I have. She wrote a book on the glyphosate stuff. I don't remember the title of the book, but she published a book probably 3 years ago or 4 years ago
Okay.
on glyphosate and the effect on the environment and everything else. So those
Right.
of you who want to read that book, and she came several times on Dr. Mercola's show, and they
Right.
had a lot of videos about that.
Hey, since you brought up the Amish, and I just watched 2 hour shows on the Amish, and I was raised relatively Amish. I would like to say that if we look at the healthiest people in the United States now, it is the Amish.
Yep.
And one of the reasons for their growing beliefs, the way they do things, the way they farm, is
Right.
because they came from about 300-400 years ago. These are the people that realized one very important thing. And that important thing is they are trying to kill you.
Yeah.
So gather in your circle in the community and try to stay alive.
Yeah.
Because for all this time, they're trying to kill you. And that is why they do not trust you. Because
Yeah.
if you look at the poisons, the toxins, the war, the killing, and remember, they're pacifists. They don't believe in war. They won't go to war. That's why they're
Correct.
independent.
Correct.
Right.
So behind all of that is the poisoning, the war, which is control, because the people who run things don't care a damn about you.
Agreed.
Correct. Well, yeah. I really think the problem is really convoluted. Everybody, I call it. That's why I wrote the book, Homo economicus. As the economic man rose, so the world have demise. Why? Because everybody looks at their pocket. Everybody wants to make money.
Yeah.
And the farmers, their goal is to make as much money as possible with a little effort as possible.
Agreed.
So what do? They use chemicals. Because if I want to go do organic farming, it's more expensive and more onerous for them to do so. So they don't want to go there. They just want to do something easy that they can make a lot of money off. Now, if you're running for Congress in your community, and it's a community of farmers, and you go tell them, Roundup is bad for you. It's killing people. It causes cancer. It causes chronic diseases and all of that. Please don't use it anymore. Well, you're lucky if they don't throw rotten eggs on you. But if they don't, the minute you turn your back, you lost the election right there. So if you are an astute politician, when you go to your constituents, you don't tell them that you're gonna fight against whatever their livelihood is. You say, okay, I'm going to help you guys. And when they go to Washington, they do exactly that. They lobby for the farmers to continue producing the toxin that feed us. Well, if you want to go differently and you want to speak against the toxins, well, the next election you lost it already because you did not uphold your promises to them. I think that's what the problem we have. We have a lot of conflict of interest in the government that is killing us all. Even though Congress in 1990 passed the Organic Food Production Act, today we produce probably 1% of organic food. Why? Because we cannot tell the farmers what to do. So what I'm thinking is maybe you should start from the farmers themselves who are dying of cancers due to the toxin that they're using, so they can do biodiversity. And the biodiversity is not a new idea. Somebody wrote a book, The Soil Will Save Us. It was a farmer in North Dakota who was using natural ways of producing without using toxins. So the soil will save us. If all the farmers learn these kind of processes, perhaps we'll do better. But nobody wants to do the hard work. Everybody wants to get easy money, including everybody. Yeah, that's my thinking. So I don't know how we're going to change this system of self-interest and willing to make money even if you're going to die from doing it.
Well,
You know what? Well, Maria's definitely on the target with all the things she's talking about with the soil. Me and my family have been living it now for 200 years. So all of my life since the day I was born, we have simplistic ways of keeping the land, and it does not cost more.
No.
If you don't
Right.
go for the temptation of increase, fourfold increase with GMOs, double with the fertilizer, if you don't fall for that, the way
Right.
my family didn't, in the process of growing the food, you build the soil. You do not delete it.
Right.
Correct.
You can add some basics to it, but the process is primarily recycle carbon. It just
Correct.
goes back. The soil builds up, and you go from 1 inch to 10 inches. Now it holds the water. And for some crazy reason, just like that South American soil they made,
Yep.
if you do process it for 10, 20, 50, 100 years, that soil somehow becomes rich.
Right.
Yeah,
So
I know the technology exists, like the carbon thing that you're telling about. It
Yes.
exists actually. People use it, but to use it at a larger scale and teach the farmers to use it, that's the problem. I don't see anyone doing that.
well,
We,
the dumb part is that it's not less work to do it the way they're doing it. It's a lot more work, and there's and like you said, they're all sick. The farmers are sick,
Yeah,
and
themselves.
yeah, and the work, the crops are more sensitive. They die easier. They're not healthy. You know, the insects love them because that's what their job is to get rid of the junk stuff out there, and so they're more attacked, and so they have to use more chemicals, and it's a big vicious circle. So education, and Dr. Tano, you're the best educator I've ever met in America. I mean, since I was a kid anyway. We used to have good education, but we don't anymore, apparently. And so nobody even knows that they're eating stuff that shouldn't even be called food. That's it's a sin that they call Doritos food. I mean, it's not food, it's not.
Or Cheetos or what they call it. Yeah. The kids, the problem, it starts from the schools, for instance, like the school lunch. How can we feed children toxin and expect them to excel in school?
Exactly.
But there's no way. I mean, I really think that is a crime against humanity for doing that. I think all the states should think differently and feed the kids good food. At least the minimum they can do is give them organic food rather than using the money for nonsense.
Well, they claim the kids don't like it, but I don't believe that. I believe that the kids haven't been used to good food, so they're used to eating garbage. I mean, if you have a pizza in front of you, are you going to eat, vegetables that are maybe not quite so flavorful? I don't know.
And we shocked that kid now they're getting colon cancer. A lot of young kids are getting colon cancer, but We still don't put two and two together, which amazes me. It's like, wow.
Well, that colon cancer, was it not getting a boost from the COVID shots?
That could be too.
Yeah, there was a marked increase in the colon problems with kids that was never there. And
Right.
that came with the COVID shots, which you guys know it knocks down COVID vaccines knock down what is it, P53, which is the anti-cancer SNP or whatever that gene is. So COVID is directly fights that particular P53 that stops your cancer.
Right. Well, that's not directly. It's through renin-angiotensin system. And I send some articles showing how the spike protein activates the renin-angiotensin system, the inflammatory arms, which will lead to an activation of P53 and lead to cancer. But there's a chemistry behind it, mechanism behind it. Starts from ACE2.
But I think
Blocking.
P53 is the protective mechanism of cancer. Am I right?
Exactly.
It goes through your little DNA and cleans it up.
Right. It does induce apoptosis and, for the
Yeah.
cancer, I think.
Yeah.
And they're being compromised by the spike protein through the ACE2 blockage and reactivation of the inflammatory oxidative arms of renin-angiotensin system. So there's a mechanism. If
Yeah.
somebody wants a mechanism, okay, that's the way. I mean, people, it's not direct. The spike goes interfere with P53. It's indirectly through renin-angiotensin system. But it's true. And if somebody needs the evidence, I can share with them the whole chemistry behind it. And yes, I mean, the whole petrochemical life that we live, it starts from the digging oil as a source of energy. I think the ancient civilization, if it's true that they generate energy by alternative mean, like the pyramids in Egypt, they think it's electric power,
Right.
and they get the energy from the difference in the thermodynamic difference between the deep ground and the surface, and they transform it into electric, the thermodynamic difference, the heat difference between the ground and the top surface, and that can generate electricity enough to really empower all these factories that we have. And I think that ancient civilization, they're smarter than digging oil and producing alternative source of energy that's healthy, because this is the cost of oil industry. We end up with all these poisons, the plastics, the petrochemicals, the smoke, the glyphosate. It's all petrochemicals. And if we generate electricity with solar and with thermodynamic and wind, I think we will be having better earth than we have right now.
No shit.
Yeah.
Right.
Well, I think
Maybe we need to reverse to that
you
point. Go
I
back
think
to old civilization.
well you can have the problems with the oil and the chemicals, but if the people who get rich by promoting those chemicals and oil, that's where the problem is. There's a human problem that could have been cleaned up, whatever, 70, 100 years ago with the technology you're talking about. We already have it. What you're probably going to see in the next year or so is the government admitting that we have anti-gravity propulsion and we have anti-gravity energetic production. They've had it for 50 years, folks. They just haven't told you yet. So the people who are making money off of the oil don't really want you to know these things, but it's leaking out. You'll see it soon.
Yeah.
French is with this disaster in Iran. French said, we are a country, we don't have oil. We need to start relying on alternative source of energy. We cannot do it. And I think if they move to that direction, and France start doing it, then the whole world will replicate it. We get rid from this oil industry because I hate oil industry.
Right.
Bad.
Yeah, it's devastated a lot of lives.
Agree.
Hey, look, there's Joseph. Hi, Joseph. Dr. Joseph.
Hey, how you doing?
Hey Joseph, I'm traveling after tomorrow there. I'm gonna pick you up on Friday, right?
Yeah.
You and Sheldon.
Okay.
I'll be traveling Wednesday, and then Thursday I'm gonna see what's going on. They have something pre, and I'm gonna meet Klatz there. And then Friday I'll go and pick up my books from Sheldon, and then pick you up, and then we'll find a house on the beach, and maybe Ian Clark will come with us, and they have good beaches houses there.
Yeah, we stayed at that one place
Right.
last time, but we can talk about that later. What I
Right.
missed, I apologize. I had a
You're late.
consult
We
from
finished up the lecture. It's like
yeah, I
11.
had a famous singer call me out of the blue that happens to live around West Palm, actually.
Wow.
Oh, what's
I will
his
be
name?
coming too. Please remember me when you go book that house.
Okay.
We're gonna
True.
meet with him in West Palm Beach. This famous singer.
Yeah, well, I mean, I say he's famous, as far as he's famous around people I knew in Chicago, and probably more well known than I think. But he used to do a lot of like almost like Frank Sinatra type music at some of the downtown, some of the fancy places downtown. Like, can't even remember some of them, but yeah, no, very interesting
He
guy.
has a show
And
during the time we are there.
what's that?
He has a show during the time we are there in West Palm Beach. We can go ahead and visit him.
No, well, I told him about the show, and he lives in Boynton Beach, so he's close by. I told him let's meet up in West Palm, and he's very interested because he was asking a lot about what he could do, what's new with anti-aging medicine, and what could he do, but also has a bunch of friends and stuff that are looking for help, so I was able to help them or basically make the search a lot easier because we have most of the things that could help them.
Right. Well, that's cool.
Yeah. So what did I miss? What was the basic gist? I apologize.
Now we just talked about systems oncology. Killing the oncologists are focusing on killing cancer, and it's not about just killing cancer and targeted only one pathway. We're looking to manage the tumor microenvironment, the immune, the metabolic, the redox, the regenerative. So all those needs to be taken care.
Okay. So I do have a question, and it has to do with sort of another epiphany. These epiphanies, they seem to never end. But one of the things that became apparent is that the reason why it can be so difficult to control all of these different turbo cancers, obviously we're focusing on the milieu, the tumor microenvironment. That's really the place to focus on. But at the same time, what's becoming apparent is that the same process that's causing the chronic inflammation that's leading to fibrosis, that's leading to Th17 polarization, interleukin 6 activation, but it's chronic activation. And that's been the thing that maybe this is obvious, but it just didn't click for me. Why does it seem like you can treat these things, you can modulate them, but they never seem to go away? Okay. And what I mean by that is it's been harder and harder to treat chronic inflammation that leads to the instability of the genome,
and the different levels of transcriptome and metabolome, and that at some point the tumor suppressor genes get affected, or the whole machinery switches to a different kind of metabolism. Different pathways get activated, or in other words, the DNA may reprogram metabolism to shift into the kind of metabolism that would favor glycolysis. Well, then the question becomes then, how do we get the genes to reprogram back to the way that they should be? And then the realization that there's multiple levels of genomic control, because we've got the genome, we've got the epigenome, we've got the transcriptome, the things that are actually could be overly sensitive that are activating the genes to be activated abnormally or overexpressed. And we've got the metabolome, basically probably having more to do with the mitochondria, proteasome, proteins that are supposed to be enzymes that are not fully functioning. And really, there's 7 of these systems. So is it possible that we can actually do a test that would actually reveal all of those overactivated, underactivated levels of the control that would be dictating why a tumor environment would be formed in the first place, and that we create a multi-peptide small molecule concoction that addresses 10 things at once, with the hope that if you can modulate the entire system, that given enough time, if those genes, will say that genetic expression is stuck, it's not like you just, oh, let's modulate it and then it goes back to normal. It's like when a gene gets reprogrammed, a set of genes gets reprogrammed unfavorably. It's like a piano key gets stuck. It's just you can't push on it and expect it to bounce right back up and start working again. The whole thing, and you can't just focus on one thing, right? One lever. What if there's 10 levers? And that if we address all 10 on different levels, that given enough time, either those cells will die off and some of them may actually start to reprogram back in the right direction, the favorable direction, and not the degenerative cancerous direction.
Well,
that's my epiphany.
Well, in general speaking, about inflammation, and there's also for cancer. And we talked about there's 2 parts. There's genetic SNPs, and then there's environmental modifiable factors. I think for modifiable environmental factors, we need to prioritize things that's affordable and not going to more expensive ones. And if the treatment is not just about doing it all at once and cost too much of dollars, it's also performance and efficacy. And if we prioritize the big things that is modifiable, like the diet, the toxins, and changing those environmental factors into the healthy ones, the insulin level, which is the big driver. And I'm not talking about cancer right now, I'm just talking about general. And you start going step by step, and then you go ahead and do some genetic SNPs and finding them. And those genetic SNPs, most of the time, it can be affecting the metabolism of vitamin D, B12, of clotho, or vitamin D. And you come up with knowing some supplements that helps to kind of override or compensate for those genetic SNPs. And those are genomics things. And there's epigenomics as well, testing for that as well. And for epigenomics, it consider modifiable factors. But for genetic SNPs, it's difficult because you cannot change them. but you can kind of compensate them with constantly, giving them extra vitamins that they are having problem with metabolism, or looking at the detox and giving them some extra antioxidants, um, or giving them clotho and things like that. But it has to be done and efficient, and you don't go into genomics and the patient is having too much of heavy metals and toxins and high insulin, and you say, I'm going to do genomic tests and find out the genomic steps and working on the deeper. You have to do it layers. And those genetic steps are not fixable. I mean, you cannot reverse them. So if you have them, you have them. But it's like going against the flow of the river. You you have to add all these things that you're doing, and I think you are a typical person. As I said, if you take off everything that you're taking currently, you will be like, bubbling with inflammation. But the reason why you are relatively healthy, because everything that you're doing, and you're figuring out more layers and more layers, and you're getting better and better. But if you stop everything that you're doing, you'll become like bubbling up like a boil with inflammation. And unfortunately, that's because of the genomics SNPs. Do we have anything to fix the genomic SNPs, like changing the genes? We don't yet. Maybe in the future. But as long as you go step by step and reasonable, then you're on the right path. But don't go into deep things before you do the basics. That's my best recommendation here. Does that make sense, Dr. Joseph? I don't know. Hello?
Oh, I thought you muted me. Can you hear me?
No, I did not muted you. Does that make sense? I can hear you.
Well, it does. It does make sense because
Right.
we're speaking the same language here, and it's true. You don't go for the genetic modification before you address the other issues. And I think the thing I'm bringing up might be more, well, it is more relevant in the context of the patient population that I'm treating. And then there's another thing. I think part of the epiphany is it's not the genomics. Okay, the genomics are there. I call those the vulnerabilities. I mean, correct me if there's a better way to state it, but there are issues that I would say on the epigenetic means that, from my understanding, that's what's being expressed now. That's an overexpression, overproduction of something, overproduction of interferon, underproduction of interleukin 10, overproduction of, different levels. Like I said, there's the epigenetics, the genes that are overexpressed and underexpressed, dictated by the vulnerabilities of if they're stuck, most likely because there's an underlying predisposition or vulnerability that at a certain amount of stressors, toxins, and heavy metals and all the things will cause the expression of those genes that keep the person in a vicious cycle that lead to the transcription factors, some of them being overly sensitive, some not sensitive enough, that cause the underproduction of certain anti-inflammatory, major regulatory cytokines that cannot put out the fire because the system is overwhelmed. And the patient population that I see, they are, I would say they are the patients who probably do more than anybody. And it is their genomics and their predispositions, because nobody has a better diet than my patients. I could literally, if I were to get their information and put it down, I would be confident that their lifestyle and their diet would be superior. literally, but way better than me. I mean, I don't even compare to these people. These people fly to different countries. They've been trying, some of them have been on the search for 20, 25 years. And the obvious explanation is because the world has become extremely toxic. Well, they are probably, I say this, their superpower has become their weakness in this environment. This environment, and I've got my own opinions and theories behind it. These people would be unstoppable. In fact, they would be a threat. These people are extremely disciplined by nature and targeted. And it's like kryptonite and Superman. They are knocked down. They go from flying, they've got their cape, to being bedbound, or they're on the ground. If you ever see a Superman movie, you know, they go from the strongest to the weakest. Now, to think that they're just going to magically get better, I mean, that's sort of unrealistic on my side, even though I'll never stop trying. But what I'm seeing is that despite doing all the things, it makes me question, because they've had the epigenetic expressions and the different levels that go along with it, do they become stuck genes? Do those genes get stuck? Meaning that now it's not just going, they could do all the things and actually get into a bubble free of toxins, and they're not going to feel any better because now their genes are permanently activated. It's like their body does not forget that they are in danger. Okay, so then the question is there another level where we can target the 10 most important dysregulations at the same time, and that may be powerful enough to help to reset the DNA expression?
Yeah, epigenomics are modifiable. So those still it's considered modifiable agents. And you can test them and you can come up with protocols to modify it and restore it back to healthy expressions. And yes, and the toxins and all that can change epigenomics. So it's and nutritional deficiency and things like that. So at epigenomics, we can do some solutions there. We can fix it.
Let's forget.
But if it comes into genetic SNPs, we can compensate.
No, it's not about that. Let's forget about eating healthy, because I'm talking about the top of the top. I'm talking about people who eat superior to anybody on this phone call. Okay, who know more than most of us. I want to make that clear, because I don't want the fallback to be, well, it's nutrition and stuff. Bullshit.
Right.
Bullshit.
So after that level, you may do some.
We know too much. We
Right.
know that the food is poison. Okay, it is absolutely poison, no matter where you go. Okay, so there's an urgency at hand that, and I think this lines up with cancer. Okay, that it's the same thing. Those genes, the epigenetics, they are stuck in an overexpression that is affecting the different levels of control, the control mechanisms, the pathways, the overexpression of fibrosis. That if and we're already doing it to a degree. What I'm suggesting is, if we could figure out how to make it affordable. Okay.
Yeah,
How
so
about that?
Clo2 is a good one, and oxytocin and those executive things, when you end up doing everything and still they are there, so you can just go ahead and torch them with Clotho and exosomes and things like that to may end
Well,
up
I don't know.
having
I don't want to guess.
right. Yo,
I don't want to guess.
you need to do some epigenetic testing, coming up what's the problem, and then throw the AI based on all the researches and publications out there, they
Yeah.
will tell you use this and use this and use this. This is the problem these patients have, and this is the thing that can be compensate and can help in overcome those abnormal expressions.
Yeah, because I think that this is where things are headed. I'm just giving us a heads up.
Right.
I'm asking sort of to, so that it becomes discussion and maybe we get, build up some ideas. The reality, there's no doubt. I already know that this is the case because I see the epigenetic reports and I do have people that they're doing something called personalized peptides that takes peptides that are not the typical ones. They come from a library of peptides, a design that is targeted.
Right.
And then does use AI because of the,
The data is too much for the
the
human can
quote
do it.
unquote, there's a billion combinations
Right.
that could be how they could be put together. And it's deciding what would be the best for those. And the reason is because there's a growing number of patients that I have that are 21 years old, hockey player,
Right.
homebound. I'm getting an increasing number of, I had a 33-year-old actually came by to the office, successful, the whole thing. He's now unemployed. I mean, everything going for these people. And you would not even, you'd look at them and they don't look like somebody who is, you know, first of all, that doesn't know how to eat and they're not your typical person. You see what I mean? These are the people who there's something terribly wrong
Right.
and nothing is working.
Right. And those people, they need to go ahead and go more extra steps. And they may have genetic SNPs too, not just epigenetics. And you
Well,
can still fix those genetic SNPs, not fixing it, returning it normal, but compensating it by expressing more antioxidant, more anti-inflammatory, adding extra clotho, extra vitamin D, B12, whatever, that require peptides, specific peptides. So you are just, compensating their defects. And it requires some active and extra money sometimes to really
well,
optimize them.
these people are desperate. They will do it.
Yeah.
There's no question. In fact, it's going to happen no matter what we say on this call. It's already done deal. That
Right.
that 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 train is headed. They're not waiting on us to get there. Okay, it's already happening, and it's
Right.
because they are the canaries in the coal mine. There's always been those patients, but it's getting to the point where it's it's hitting younger people. It's 21, 33, top tier athletes, the ones that are wasting away in bed for everything. The doctors are scratching their head and well, the epiphany, because I've been laboring over this, dealing with it on a everyday basis. Those are the patients that I see that what seems to be happening is that despite taking 25 supplements, knowing listening to every podcast imaginable. I mean, these people are hyper intelligent too. There's a similarity that they have,
Right.
and they are targeting everything. If they haven't, and some of the things they haven't done from us, and they get benefit from the things. But the big question is, are those epigenetics, that transcriptome, that entire machine, are those genes stuck? And if they're stuck, can we recondition them to be unstuck? Not the SNPs, the overexpressions and the underexpressions. Like I'm
Yes.
stuck. Okay. But
Epigenetics, once you know there's problems and they are not benefit from the basic things that you're doing, then you need to go to that next level.
nothing on
Right.
this end is basic.
So peptides will be an answer for those people and personalized peptides based on their epigenomics. Uh, I agree with you 100%. And those people, they are alpha people. They want perfections, and they are high skilled people, and their whatever jobs that they're doing is demanding high performance, then yes, you can
Well,
end up
the businesses that they run and own require high performance.
right.
Yes.
So you can with your scale you can get them to that level to
Okay.
match their needs.
Okay.
Right.
Yeah, because I just want to, I think it's important realization is you can have, the whole system can be stuck in a vicious cycle. Okay, for example, me, apparently I overproduce interferon of all things, a very specific interferon, typically the one that's activated by the toll-like receptors. And I underexpress interleukin 10 and I underproduce glutathione. And there's evidence that my mitochondria is leaking DNA and perpetuating the cycle. And I went through it with chat in depth, deep, hours upon hours, built upon multiple results and heavy metals, all the things. There's not anything that I have not looked at that we haven't already talked about. Okay. And even chat said, you fasting isn't going to do it anymore. You cannot, said you're not going to be able to do anything that is being advised. Like you're stuck in such a vicious cycle with the predisposition that you cannot reverse it. And if they say that you can, they don't know, because they don't even understand what is being overexpressed and underexpressed. They're not speaking the language of epigenetics and the transcriptome and the fact that the influenza. See, aren't you glad I got on the call? You got to have a dose of this every week. The interferon receptors are overly sensitive. Okay, there's all these different elements in the machinery that can be addressed if we know what they are. And we're talking about people who are not getting better.
Right.
But that's who we attract. We're not a
But they're
Medicaid
more than
clinic.
epigenetics, those people. They have also genetic SNPs. And you still can work around genetic SNPs, just you need to
Well,
give them
well,
more.
put it like this. When something's not working, then we have to take things to the next level. We've got to go to a deeper understanding and a take what we've learned and apply it to another set of knowledge that's very real. If somebody's
Right.
not getting better, it's not because they just can't get it together. It's because we're in an unprecedented time. It's
Right.
unprecedented.
Yeah, but most of the people does not respond to the basic regular things. Sometimes it's not just epigenetics. They already have underlying even genetic steps. And still you can help those people, but they require extra things than the normal person who does not have genetic steps. Does it
That's
make
that's
sense?
every that's
Like patient
every.
has gout and genetic SNPs with gout, or psoriasis with
Oh no
genetic,
no no!
rheumatoid
Look,
genetic SNPs, and he will tell me this person, okay, he wants to be playing soccer. Can we do it? Or play hockey or whatever, any games that require high performance. It's still they can, but it will cost them doing a lot of things extra than somebody without genetic SNPs.
yeah. Well, exactly. Well, this isn't a family practice that is run over here.
Right.
And I didn't spend $1 million on all this education to be, oh, here, here's some colchicine. You're fine. That's not, every single one of my patients is a mystery patient. Every day, one after another, after another, after another, after another. In fact, I don't know what it would be like to treat a sore throat or to treat the basic things that we seem to be talking about. I'm talking about hardcore, just like treating the cancers, but they're related. It's
Right.
just that their expressions are not in the form of cancer. They're in the form of autonomic dysfunction. They're in the form of chronic neuroinflammation. neuropathy, all the small fiber neuropathy, all the different gut issues to no end. But it's still on the same spectrum. It's just that it's the same thing, different genetic SNPs. The cancers are the genetic SNPs. That's the
Right.
reflection of what the genetic SNPs are. It's presenting as cancer, right?
Right.
For me and the patients I have, it's expressing at debility. The
Right.
inability, a 21-year-old hockey player who now cannot have a life, can't leave the home, and nobody can understand them. They think it's this, it's that, or you just got to get it together, when really they don't know. Because I know that they don't know. It's obvious. Because otherwise they would be able to explain it and give a reason why. Why is this 21-year-old, why can't he get it together? Why can't he play hockey? Why can't he go out with friends? What's wrong with him?
Right. Yeah,
And
those
this
are
is
complicated cases. When the system fail, they just dump them and they say we don't have an answer for them. And sometimes it just classify them crazy or psychological
no,
problems.
these people are high class
Right.
people. I'm not meaning they're more valuable, but we're talking about something that's real. That's what we attract. If we're not the conventional, then we're attracting the people who are desperately seeking solutions. And there are a lot of them out there. It's just that they're maybe 1 in 50 people, 1 in 100. Okay, something like that. Maybe it's 1 in 25. I don't know, but it's a growing population. It's a society that's rapidly getting sicker and sicker and sicker,
Right.
that demands that we approach chronic disease like cancer, because it's the same issue, different genomics.
Right. No, I agree with you. Yes.
Okay, so otherwise it doesn't make any sense for me that why would I even, I mean, I'm not a family practitioner, right? It's not about me here, but well, it is right now, but I'm not a family practitioner. I mean, I'm not, people aren't paying money to have to have fancy tests, to have their endothelial testing, although it makes sense. But people aren't paying for that. They're paying for an answer that they're desperately seeking that they cannot find. We are in the perfect position to be the right people at the right time. We understand the mechanisms. Nobody else understands mechanisms like this. And I know this because when I talk to anybody in the health field or people in general, I do not get a language to go with their statement, a reason why. And I ask them, and I can tell because of the answer I get that they do not speak this language.
They are
I
not
think,
incentivized to learn above what they are being taught or being dictated by the big pharma. And they cannot do anything above it because they are insurance dependent. And if they don't free themselves and become free thinkers and become doctors with looking for solutions, basically they're just providers, most of them. So the few like you and Tano and William Clearfield, you are thinkers, you're doctors, real doctors. But most of the docs out there, they're just how I can finish up the day, get paid, and have fun.
yeah,
Right.
it sounds pretty miserable. Well, I guess
They see
each one
us
thing.
crazy and miserable, those doctors. So they say, "Oh, this doctor's just a crazy doctor."
Yeah.
Just give them cortisone and narcotics
Well,
and get rid of
well,
them.
yeah. I mean, that says something about them. I mean, if they cannot see that it's not 1970,
Yeah, that's the
it's not something that
difficulty.
there's something wrong with them. That's not
Right.
us. It's not my problem. I gave up on worrying about that stuff. I'm concerned about now. What we need to do, I'm just letting us know, this is the next step. there is a company that does personalized peptides. My intuition here is that we're in a time now where this is going to be necessary for both cancer, that we just have to take, look, we know how to target mechanisms. All we need to do now is why do the epigenetics, right? If we don't target them, why can't we take peptides to the next level? Why do we have to keep relying on BPC 151, thymosin alpha, thymosin beta, when there's thousands of peptides out there? They don't, with codes that are unrecognizable, that can target all of these, pull all the levers, all the things that are pulling the like the puppet master here. You know what I mean? That we can address all of those strings, all of those levers at the same time, even more precisely. It's the same concept. We just have to figure out how do we do it without, crossing a line or if anything, maybe it's just, that's how we just need to think about it. That the reason why some people are not getting better is that there's more mechanisms, there's more specific expressions that are making this person different than this person. And if this person isn't getting better, if we fall back to, well, you just need to get, eat better, you're lying. It's because we don't know. People say that when they don't know. Because I've never had anybody say, okay, here's exactly what to eat. You do this, and they stick with you. And they actually encourage, say, hey, if you do this one thing, watch what happens. No, it never happens. They say it because they don't know what else to say. I think it's a good idea. It's in our best interest if we actually take what we learned and take it to the next level. Let's get more specific with the peptides as a way to think about it. If somebody's not getting better, maybe it's not them. Maybe it has something to do with we're dealing with things that are hard, that we cannot control. I mean, I know this to be the case, but I'll just say maybe there's something happening, something out there, maybe that's the case. And that it's too much pressure and stress on certain genetic combinations. I mean, heck, they're paying us. Why don't we give them a solution? Okay, so anyways, that's enough about that. I think that's a way to think about it. But putting it into perspective, you cannot change the genomics. I get it. But there may be another level of specificity, accuracy we can get targeting, just like we're treating cancer. Okay, anybody else?
Glad you came on. Perfect timing.
Thank you very much, Dr. Joseph. You're the best.
All right.
See you after tomorrow, man.
Okay.
Amen.
Well, Friday. I'll see you Friday.
Okay. Good enough. All right,
night,
guys.
everybody.
All right. Okay.
Take care.
Thank you so much, everyone.
Okay, bye.
Hoorah. Bye-bye.
Thank you.